moving from breast tumors and lung, which are all hidden areas. Here we have something which is very presentable area. If you see head and neck area or the face and the head and neck area are the most visible part of somebody's body and something where people would like to show off. But we often, though that is a fact, we often see that 60% of our patients do come in very late, advanced stage. It's mainly because of late diagnosis, late presentation. And one thing where we can do is early diagnosis. And as you all know, early diagnosis would give a better result. So I will be touching upon the evaluation of head and neck cancer. It is going to be very simple. I think it's a basic MBBS level discussion that we are going to have. When I say head and neck cancer, we mean the cancers of the oral cavity, of the pharynx, which includes the nasopharynx, the oropharynx, the hypopharynx, the larynx, the thyroid cancers, which is in front of the neck, the salivary gland cancers, which includes the parotid, the salivary, submandibular gland, the sublingual glands, and cancers of the nose and the paranasal sinuses, including the periorbital area, and the cancers of ear and temporal bone, which is very rare, and also whenever some patients do come with a neck node and we are unable to find any of the primary in any of these areas, we call them as carcinoma of unknown primary, and some skin cancers of the head and neck area, mainly of the face and the scalp. So this includes the whole gamut of head and neck cancers. And it's pretty simple. Many times we get a patient like this, maybe a young male or an elderly comes with a node like this. And the first question would be whether it is a malignant node or a malignant swelling or not. So how do we differentiate them? I think any third year MBBS student will tell us that any swelling which is of recent history, which is growing fast, which is hardened on palpation is likely to be malignant. And that's what we do. And if so, what we do with these patients? We do a diagnosis by a thorough clinical examination. Dr. Gangadharan sir was pinching upon that point, because clinical examination is one of the points which is very, very important. Though we say that, we many a times see that many of the juniors do miss cancers of the oral cavity of oropharynx in patients who present with neck nodes. We know that it could be from these areas, but still are missed. So a thorough physical examination is what I would say to get a diagnosis. And many, the biopsy is the confirmatory test. Imaging will help us in staging these tumors, because what we have to know is the third dimension. We may see what is in front of us, but there is a third dimension which is the depth of these tumors, and that will help us to identify the stage of the tumors. And along with it, especially in head and neck cancers, I think it will amount to any of the oncology, but especially in head and neck cancers, because what makes it different is the head and neck cancers occurs in a complex area. This is the area where the patient's swallowing functions occurs, the patient's breathing occurs, the patient's talking, day-to-day activities occurs. So it's a complex area, and any problems in these areas are going to affect these functions. So patient may not be able to eat well, their nutrition will be very much decreased. They will have a psychosocial problem because of the diagnosis as in any of the cancer patient, and we will have to address these as well. So if you see this oral cavity, the usual symptoms that an oral cavity patients do come up with is the non-healing ulcer in the oral cavity. It may be painful, may not be painful, but many times they ignore this because it was painless. And if you see, we know the etiology of oral cancer patients. It is the tobacco use, tobacco either in smoking form or the chewing form. And these patients do not have a good oral hygiene. So what happens, they will ignore everything. And when they have pain, the usual, you would have seen many patients, the usual habit is that to get rid of the pain, they put this tobacco into that. They see that it is a tooth pain, and if you put the tobacco there, it will again reduce the pain. And that keeps on going, and then ultimately they will have a loosening of teeth, or sometimes odonophagia, or it may even lead to dysarthria if the tumors is of the tongue, and they may also present with neck swelling. And that is the situation when they would come to us. That means it becomes already an advanced tumor. So these are situations where the patient has a non-healing ulcer of the tongue, and how to diagnose whether it is a simple aphthous ulcer or a malignancy is a bit of experience. Many times we will have to, if there is a doubt, we will have to get the help of the senior colleagues or a specialist. Whereas the diagnosis is very easy when the patient comes in this stage with a large ulcer in the mouth which is coming through and through into the neck. But it is much more easy when it is in the oral cavity, because the moment you open the oral cavity, you can see whether there is an ulcer, a tumor, or a loosening of tooth or anything there. Whereas when it goes to pharynx, many times the diagnosis is going to be much more difficult, even for a person like ENT surgeons who are dealing with these areas, because many of the symptoms will be not specific to these areas. They may think that an odonophagia or a pain in the throat or even an ear pain will be related to some benign conditions or infections. So it needs some time, it needs some specific investigations to see whether these symptoms, especially all these initial symptoms, are causes of malignancy, are due to malignancy. But whereas when it enlarges, when the tumor enlarges and causes some amount of dysphagia, neck nodes, or stridor, the diagnosis will be much more easier. Whereas that is something mainly related to the pharynx, and that is why many times we get pharyngeal patients in advanced cases. Whereas when it comes to larynx, that is not so. The specialty of larynx is that the moment you get a small host, even I have voice now because of my respiratory infection. The moment you get a little bit of hoarseness, a little bit of changes in the vocal cord, it presents as a hoarseness. And if not you, at least your friend or your relative will say that there is something with you, your talk is not good, you better go to a doctor. And as it progresses, it will soon develop into a stridor, and some patients may come with hemoptysis, and all the other things do happen when the tumor from the larynx get out into the pharynx, and the same symptoms will be there. So we often get laryngeal cancers in early stages. This is mainly because of these factors. We know thyroid tumors or the tumors in the neck are usually present with neck nodes, neck swellings. But sometimes these neck swellings are ignored because we see many patients roaming around with the simple goiters. And many patients also would think that these are all simple goiters because their relative also had some swelling like this and they never had any problem. But problem would be when these cancers infiltrate into the surrounding areas, because a thyroid cancer can infiltrate the nerves there, causing hoarseness. It can push or even infiltrate the pharyngeal or the esophageal area, causing dysphagia, and sometimes they may also have metastasis and they would present with neck swelling. We recently had few patients who had a neck swelling for about 6 years, and that was a metastatic node, even young female. That were metastatic node from thyroid cancers, and that is the rate of growth. As somebody was mentioning the rate of growth of some cancers, but thyroid cancers, mind you, do progress very slowly. That is why these patients were going on with these tumors for 6 years, and then they presented with to us. And then when we investigated, we found that they had thyroid cancers. Salivary gland cancers are very common. Salivary gland tumors are very common nowadays. I don't know whether it is because of the changes or the habits that are being done. And Nitin very vehemently said that the mobile phones do not cause any harm. But there are studies saying that mobile phones and salivary gland tumors are associated, though it's not proven beyond doubt. But somehow we see lots of parotid and salivary gland tumors, but all of them are not malignant. But how do we say whether it is benign or malignant? We will have to get the help of Lily madam or their colleagues, because many a time the clinical symptom or the clinical picture doesn't correlate with the pathology. They may feel very firm, very soft, but the FNAC may give us a better diagnosis and it will tell us more about that. So any of these swellings, and they also grow slowly. So any of these swellings, we do put a needle into it and make a diagnosis. And some very rarely only they would present with other symptoms like symptoms of infiltration like pain, facial palsy, etc. If it is a parotid tumor which is infiltrating into the facial nerve, they may present with facial palsy, but that happens rarely. Many a times it is the swelling that is usually the patient complains. Coming to nose and paranasal sinuses, again the symptoms do mimic a usual allergic or the nasal polyp symptoms. They may present with a nasal obstruction, some kind of sinusitis symptoms, and some patients like this may present with a swelling in front of the face. Because maxillary sinus is something which is there deep inside, any swelling inside which is arising from the maxillary sinus will present only once it is outside into the skin. Until then they will be presented, until then they will be treated either as a sinusitis patient or as a dental pain patient. Or they will be present to a dentist and will be under treatment for tooth pain, and tooth extractions will be done in many of these patients. But some of them do, when the progress will come in these kind of stages. But if there is an epistaxis, if the epistaxis is one of the early symptoms, that is when an ENT surgeon will surely do an endoscopy and try to find what is inside. Many a times they will see a mass inside the nose, and they will not be able to differentiate whether it is a nasal malignancy or a benign polyp, because again there are various situations in which we can have epistaxis even in a polyp conditions. So, but then biopsy is the thing that is going to help us. Skin cancers are not so common in our part of the world because our color and the melanin content are helpful, whereas in white populations it's a very common condition, especially in parts like Australia, US, etc. Their major illness is thyroid cancers and skin cancers. Why thyroid cancers? It is because of the early diagnosis, because of the imaging modalities that they do for various other factors, either for screening, either for the routine workup or the executive checkups like that. They pick up lots of thyroid and they get that small 1 centimeter thyroid malignancies. Whereas skin cancers are very common in their list because of their skin condition. And these skin cancers may present with a non-healing ulcer like this, or sometimes it may be just a nodularity, or even a swelling. It may present as a swelling, and sometimes a recent change in some of the pre-existing lesions or the molds. So this is a melanoma which is there. So whenever these patients comes to us with any of these symptoms, what do? Yes, of course, a thorough examination. I told you examination is very, very easy. We just have to examine the neck, we have to examine the oral cavity, the whole of ear, nose, throat areas, and sometimes we may have to use some adjunct to see the other areas. Especially when we see the neck, we often have to palpate each area to see whether there are multiple nodes, whether there are thyroid swellings, whether the laryngeal cartilage is in good shape. Oral cavity, we have to inspect many areas. There are some hidden areas like retromolar trigone area, which is behind the molar, where we may see some ulcers. Always tongue cancers will not present with an ulcer or a swelling outside. Sometimes you may just have a normal mucosa covered with a swelling inside, which will be diagnosed only with palpation. So palpation is a must in tongue and the base of tongue cancers, and other areas we may have to use endoscope or the other special adjuncts. As in this patient who presented with epistaxis, a young lady, a nasal endoscopy was done, And here, what you see is the nasopharynx, and this is a mass in the nasopharynx, which was the cause for the epistaxis. Once we get to know what is there, either it is an ulcer or a swelling, probably in many of the other areas, like if you heard, whenever there is a suspicious lesion in lung, they take an imaging. When something is there in the breast, they take a mammogram. But whereas in oral cavity, you don't need to jump directly into imaging first, because whatever you see is the tumor, and just you may have some kind of extension deep inside. So many times we may not jump into an imaging directly, but yes, in textbook says imaging is the next modality. We may do a biopsy, confirm it, and then do an imaging. But whenever we have to do an imaging, the contrast enhanced CT scan is the main or the most commonly used imaging, because we know there are some bones and the cartilages which are there in the surrounding areas. We have to know whether these are infiltrated. If the bones or the cartilages are infiltrated, it becomes a stage 4 tumors many a times. So to know that CT scan is the common one, but also we can do a CT thorax in many of these conditions to know whether lung metastases are present in advanced cancers. Sometimes we may have to take MRI scan, especially to know the soft tissue extension. In tumors like parotid, we may do an MRI scan. In tumors like tongue, an MRI scan is better. And PET scans are usually considered in advanced cancers, because all the head and neck cancers follow a certain pattern. We should understand something, one factor which is there in any of the cancer is their biology. The biology of many of the cancers are different. Biology, what we mean is how they behave. So, head and neck cancer has a particular behavior which we have been acquainted with over the years. They do follow a particular pattern in which they progress. That is why, if the clinical examination does not show much of metastasis, we may not directly jump into PET scan. But whereas certain tumors like breast or an abdominal malignancy may throw metastasis at an early stage itself. So in those conditions, PET scan must be a sure shot diagnostic tool. But we do PET scan in many of the conditions. This was the CT scan of the patient whom we did the nasal endoscopy and found that the reason for epistaxis was the tumor here. Here you can see the fossa of Rosenmuller is completely effaced, and there is a tumor in this area, and which turned out to be a cancer of that region. Similarly, a tumor in the larynx which is going down into the trachea, causing total obstruction of the area. You can see that the air in the tracheal area and the subglottic area is completely gone, and this has gone into the cartilage and causes erosion of the cartilage. So making it a stage 4 tumor. Similarly, an MRI scan of the parotid region showing that there is a tumor here in the parotid. And in certain advanced conditions like this, with an oropharyngeal tumor, the PET scan will clearly show that tumors were all it has spread. Here you can see that the tumor has spread into the neck nodes at various levels and also onto the opposite side. So these things will be obtained only with imaging, and then would be the diagnosis with a biopsy. Again, here the biopsy is often easy because the lesion is very visible. Whenever there is a visible lesion, we would take a punch biopsy. It's an easiest option. It can be done in the office itself, in the OPD itself, and sometimes we may have to do incision biopsies as we do it in breast cancers. And excision biopsies are rarely, very, very rarely done. Many times we see that some of the doctors in the peripheral area do an excision and send to us, and that makes the whole scenario a little complicated. So our advice is that excision biopsy has to be kept at the last, and if at all somebody is doing an excision biopsy, it has to be the oncology surgeon who is going to treat the patient further, because otherwise it is going to affect the whole scenario. So if there are swellings in the neck, FNAC is a simple tool which will clinch the diagnosis. And also it can be helpful in thyroid and salivary glands. In whenever the tumors are not that big, usually we would use an ultrasound guided FNAC and punch biopsies from the oral cavity or oropharynx. Endoscopy is used as a guide for biopsy for the nose and the pharyngeal areas, and sometimes for the glottis tumors you can see your ENT surgeons doing microlaryngeal laryngoscopy with biopsy. So pretty simple it is. There is nothing much to. We don't use. We don't have too much of confusions in these areas. Only thing is that you have to keep your clinical acumen on your forefront. And once the patient's diagnosis is made, it's our routine practice to assess the nutrition. We make the patient to be seen by a dietitian who will do a clinical assessment by doing the basic parameters, and then dietary modifications will be started from the day one onwards, so that the patients, by the time they come for the treatment, they are well prepared, because that will help us in preparing the patient well. And also, any patient who is diagnosed with cancer are not those happy patients. They may not think in the way that okay, they have to rush to the doctor and they can get cured. There will be so much of hurdles in front of them. They may think that it is an incurable cancer. And there have been many incidences. I think when Gangadhar sir will be telling, there will be many incidences where we have diagnosed the patient and we would check back what has happened to the patient, why they have not come for the treatment. And there are incidences when we came to know that the patient has committed suicide. They went back after the diagnosis from our OPD and then has committed suicide because they don't want the family to get the burden of diagnosis of cancer. They know it is going to be long, it is going to be economically causing trouble to them, and even the prognosis may be a little bad. So many times these things do happen. So a psychosocial support is needed either from you or your psycho-oncologist. So this way we will be able to evaluate a head and neck cancer patient, and then the treatment would come, which is going to be surgery, radiotherapy or chemotherapy. In head and neck cancers, many a time surgery used as a first modality, and then radiotherapy and chemotherapy are used as adjunct treatment for further prevention of recurrences. And certain situations we may have to use all these treatment in different successions. I think that way I conclude my talk. Thank you very much.
Thank you so much, sir, for a very useful and informative talk. And you also made a very complex topic like head and neck into a very simple way, and you have given an overall view on evaluation and diagnosis of head and neck malignancies. And the session is open for discussion. Any queries?
How do you improve the education part in head and neck? Is it feasible now?
If you see screening, whenever we do screening, yes, of course, screening, if you do screening, it will surely become early cancers. But whether this screening as a national policy is going to help, is it going to be economically viable is the question. That is why screening is not advised as a routine in head and neck cancers. As I said, oral cancer, if you open the mouth, it is going to be very visible. So screening is going to be very effective. The largest screening study has been done at Trivandrum. It was done from 1994 to 2003 as a community-based program, which is called Trivandrum Oral Cancer Screening, which is often quoted in the world literature. And that has found that on screening, the mortality rate is reduced. They do not even talk about early detection. They say that the mortality rate has been reduced. But it is not used as a routine practice in our community because of the feasible problems associated with the funds, etc. Because there is no point in doing that. Many times, if you have done camps, you will observe that those patients who come for the camps are not the real patients. The real problem patients or the high-risk patients do not come to the camps. High-risk meaning those patients who uses tobacco or the alcohol. These are the risk factors which are there for most of the malignancies. They are least cared about their health, and they do not come for the camps. So screening is not the ultimate answer to early diagnosis. It is more than that, it would be the awareness. Primordial prevention would be a better option in many of the scenarios.
No more questions.
Thank you.
Thank you so much, sir. Thank you for the very enlightening talk.
Thank you, sir. Welcoming our next speaker, Dr. Rakesh B.A., Assistant Professor, General Surgery, DMMC, who has graduated from Mysore Medical College and pursued MS General Surgery from GMC Shimla. Over to you, sir.
Good morning, everyone. I'm Dr. Rakesh from Department of General Surgery. Today I'm going to talk about how do we evaluate bleeding per rectum. Bleeding per rectum is one of the most common thing which will come to our OPDs, and half of the people usually does not turn up because of the embarrassing situations and all. So how do we detect early all the malignancies which can be presented early so that the treatment can be started early? So, bleeding per rectum is the most common encountered problem in our OP setup. Pathology might be because of lower GI tract involvement, specifically rectal region. Hemorrhoids, fissures are the most common thing which we encounter, but even anal malignancy is also one of the things which has to be detected very early. So less than 50% patients report to the OP because of embarrassing things or embarrassing situations. So, presentation. Frank red blood exiting from anus, it might be mild, as is seen in gait of fissures. It will be streak of blood over the stool, or it might be large, severe bleeding can be seen in case of even large hemorrhoids and all. So, majority of the etiology of bleeding PRs are common problems, which are hemorrhoids, fissures, inflammatory bowel disease like ulcerative colitis and Crohn's, diverticulitis. And the one thing which we are going to focus on is colonic and colorectal malignancies, which is very, if treated very early, has good survival rate. So it's one of the leading causes of cancers and more commonly seen in European countries and northern countries because of their dietary habits, but it has been taken over in India also because of all the fast food joints, all McDonald's and Burger Kings and all. So it's increasing even in India. So despite improved understanding of natural history, it remains deadly cancer. Early detection of polyps and treatment of this surgery has good prognosis. So most common presentation will be bleeding per rectum. There will be no specific characteristics of this bleeding. But apart from that bleeding per rectum, the other symptoms are the one which will help us diagnose these things. One is tenesmus. Tenesmus means patient will be having the sense to urge to empty the bowel and will go to try to empty the bowel, but then nothing comes out. The other thing is early morning spurious diarrhea. Early morning spurious diarrhea means the patient will be, after a whole night of sleep, suddenly has to get up and go and defecate. On that particular point of time, only some amount of mucus mixed with blood is coming out. Nothing else is, no stools will be there. Some amount of stools will be there, but majority of the times it will be because of mucus and the blood. Alteration of the bowel habits and pain. Pain is usually at the last symptoms when there is infiltration of the colorectal malignancies into the sacral plexus and all. So those things will be the painful thing, or else usually it is painless. So in examination point of view, abdominal examination usually does not have anything unless the patient present to you with obstruction. I have seen 2 to 3 patients who have come with colorectal malignancies who are presenting with obstruction. When we go to do rectal examination, there is circumferential growth. So people have not shown anywhere till the growth has gone into obstruction. And one of the important thing in a bleeding PR is rectal examination. Always try to do a rectal examination. Until unless you do a rectal examination, you will not come to have a clue what the case is. So neoplasm might be felt digitally. In early cases, nodules will be felt with slight amount of induration. There might be some cases there might be ulceration. In some cases, there will be proliferative growth involving the circumferential thickening, which will be very friable, and when you do parectal examination, there will be bleeding on touch. In case of females, anterior growth, bimanual vaginal examination and parectal examination should be done so that you can see whether there is involvement of vagina or not. So, diagnosis with simple things, proctoscope, direct visualization of the growth will be there, from where you can see, and higher rectal carcinomas, you might need proctosigmoidoscope. This is Siemens forceps. Through the direct visualization only, you can take the biopsy and you can get the tissue diagnosis. As Sir said, tissue diagnosis is the utmost importance for diagnosing any malignancy. So by using the Siemens forceps, you can directly go for a tissue diagnosis and you will come to know whether the patient is having any cancer or not. Next major thing in investigating these patients are colonoscopy. So see, 3 to 5% of the patients with rectal malignancies will have synchronous growth in the colon. So we have to rule out whether any synchronous growth is there or not, so that if it is there, it will alter the management of the patient. Sometimes the stenosis which might present because of the circumferential growth might hinder the colonoscopy. In such cases, newer modalities like CT and MR colonogram can be done. As Nitin sir talked about the screening thing, it is one of the foremost thing right now going up, because as early detected, will be better treatment will be there, and early diagnosing and early, better survival rates will be there. So screening modalities are fecal occult blood test, flexible sigmoidoscopy, air contrast minima, which is now reduced, colonoscopy, which is one of the ideal one, and CT and MR cologram is also welcome. OFPT and sigmoidoscopy is only till sigmoid, it might be inadequate. So colonoscopy is the ideal thing, so that visualization, and even if any polyps are there, you can take a biopsy and diagnosis can be done. CT and MR cologram is, even though it is ideal, biopsy can't be done, but the patient will not have the cumbersome colonoscopy. So coming to the therapeutic investigation point of view, done for staging so that appropriate management strategies can be made. CT of the chest and abdomen is done to see any metastasis is there. And local spread can be done by endoabdominal USG and MRI for tumor staging. And transrectal USG can also be done to show the perirectal lymph nodes involvement, everything is there or not. PET CT is superior for knowing lymph node involvement and distal mets. This is CT abdomen showing the multiple liver mets. This endoabdominal USG showing the tumor which is invading through the muscularis propria and going beyond. This is a MRI showing the circumferential growth along with involvement of the thickness of the serosa. So what is TNM? Now we are staging the tumor according to the TNM staging. T is tumor invasion through the muscularis mucosa but not into the muscularis propria. T2 tumor invasion into but not through the muscularis propria. T3 tumor invasion through the muscularis propria but not through the serosa. And T4 tumor invasion through the serosa and mesorectal fissure. N is lymph nodes, N0 no lymph nodes involvement, N1 1 to 3 lymph nodes involvement, N2 4 or more lymph nodes involvement, and M0 is no distal metastasis, M1 is distal metastasis. This is the figure diagrammatic representation of the tumor involvement where T1 and T2 with extending beyond muscularis propria, extending beyond into the serosa and beyond the serosa. So treatment part, T1 and T2 lesions are main part of the treatment is excision of the tumor which is present. So T1 and T2 you can do transinner endoscopic microscopic surgery through whole of the lesions can be removed. And in T3 and T4 with N0 or any T with N1 or N2, neoadjuvant chemoradiation can be given so that we can downstage the tumor, so that radical procedures such as abdominal anterior resection or abdominal resection can be done. I'm not going to detail of anterior resection and all. Anterior resection usually maintains the continuity of the bowel without any this one. This is anterior proctosigmoidectomy with colorectal anastomosis. Usually done in cancers with lower margins of tumor more than 2 cm from the anorectal junction. The resection of rectum through the abdominal approach is only without any perineal incision. It can be high, which does not need any colostomy, low, which might require temporary colostomy, and we also require temporary colostomy. The main thing about treatment of the rectal carcinoma is mesorectal excision. Mesorectal excision is very important because there might be chances of local recurrence if complete mesorectal excision is not done. So mesorectum is the mesentery of the rectum, which is containing the perirectal fatty lymphovascular tissue extending into the length of the rectum. Encases the rectum as a thick cushion, mainly posteriorly and laterally. Next is abdominal perineal resection. The lower margin less than 2 centimeters, we can't do resection and anastomosis. So in those cases, we have to go for abdominal perineal resection. Whole of the rectum, mesorectum, sigmoid colon, anus, and the sphincters are removed. Inferior mesenteric artery is ligated at the root, and end of the descending colon is brought out through permanent colostrum. Palliative is distant metastasis. In case of liver metastasis, the isolated liver metastasis can be treated very with a good prognosis nowadays. So it is not taken into consideration as that if the isolated liver metastasis is there, that we can't do any rectal excision. So rectal excision is the mainstay even in case of distal metastasis. So as limited liver mets can be treated, and there is a better prognosis than before. And if it is having extensive mets or obstruction is there, now endoluminal stenting can be done. Along with that, if stenting is not available, then palliative colostomy can be done. Then laser debulking is also done nowadays. The role of radiotherapy is neoadjuvant radiotherapy along with chemotherapy is used to reduce the local recurrence, and combined radiation chemotherapy has been extremely fruitful in case of carcinoma of rectum. And palliative irradiation can be given for inoperable tumors where the patient is having pain of the local recurrence of the tumors. Chemotherapy, as we know, it's FOLFOX regimen, folinic acid, 5-fluorouracil, and oxaliplatin is used, and it's been successful both in neoadjuvant and adjuvant setup, increasing the long-term survival of the patient and combined along with radiotherapy. Thank you.
Thank you, Rakesh, for the excellent talk. So the session is open for the discussion.
Post radiation, do you actually have difficulty in surgical, like getting planes or any post-operative complications?
Yes.
Post neoadjuvant, or do you prefer operation upfront? Like, which is more simpler for a surgical point of view?
So surgical point of view, neoadjuvant chemoradiation will be given when there is less amount of margin and we can't do a anti-resection if you are going for abdominal resection. And local recurrence rates as such is less when you use radiotherapy compared to that of only chemotherapy. But there is a chances of anastomotic leaks, all these things are there. But we have to see individual basis whether we can give tumor-free margin or not, so that the morbidity or the patient's normal life is not hindered. Accordingly, we can treat the patient.
Okay, thank you, Fernando.
Thank you, sir. We are delighted to welcome our next speaker, Dr. Abdullah KP, who is a senior specialist in surgical oncology at Aston Mills, graduated from Government Medical College, Calicut, and MCH Surgical Oncology from RCC, Trinity. Over to you, sir.
Good afternoon, everybody. We will just discuss about the adnexal mass evaluation. I'm Dr. Abdullah. So, what is adnexa? Adnexa means it is the lower part of pelvis which include the ovary, fallopian tubes, broad ligament, and the fibrofatty tissues in the broad ligament. So, we are dealing with the mass in the adnexa, how to evaluate. So, it may be any mass originating from any of these tissue. So it may be an ovarian nodule, it may be a functional cyst, it may be a benign tumor, it may be a malignant tumor, or it may be anything originating from the fallopian tube, bowel, bowel, or others, like a pelvic kidney that can be present as a pelvic adnexal mass. So how to evaluate? So if it is an ovary, it may be a normal ovary, or it may be a follicular cyst, that's a functional cyst, or it may be a benign tumor, it may be a borderline tumor, it may be a proper malignant tumor, or it may be even metastatic tumor. So adnexal mass means it can be any of these things. So what are the questions you should ask? So, is that adnexal mass symptomatic? If the patient is symptomatic, if that tumor is going to be malignant or suspicious for malignant, or is going to be a borderline or is a risk factor for malignancy, if at all she needs treatment, does she need a referral to an oncologist or can a gynecologist treat that patient? If no treatment is needed, whether fertility can be preserved or not, and if the surgery can be approached through the laparoscopy. So all these questions has to be answered before treating that patient. So the treatment can be just monitor the patient. If it is asymptomatic patient and the lesion is not malignant or not pre-malignant and she is not symptomatic, you can simply wait. She needs no treatment. Or it may be a suspicious, low suspicious for malignancy. She has to be undergo a surveillance, that means she has to be followed up frequently. Or if it is malignant or highly suspicious for malignant, it has to come out. The adnexal mass has to be removed. So these are the variety of treatment. So definitely, just like any other lesion, the most important thing is history and clinical examination. So if it is a postmenopausal patient with abdominal distension, early septic, etc., it's going to be a malignant tumor. If it is a young female with asymptomatic and a smooth cystic lesion, it's going to be benign. So history and the clinical examination is very important. In examinations with general examination, abdominal, vaginal examination, and bimanual examination, everything is important. So in a premenarche girl or a postmenopausal patient, adnexal mass, unless otherwise proved, should be considered as malignant. So it should be received with more caution when examining the patient. So the problem, when there is an adnexal mass, as of now there is no protocol or a system universally accepted classification to decide whether this lesion is malignant or benign. That is the most important thing. So if there is a lesion in the adnexa and you want to make sure that whether it's a benign or malignant, usually we depend on the pathological diagnosis. But if the lesion is most of the time it will be a cystic lesion. So if you are getting a tissue is very difficult. Not only that, if the tumor is confined to the adnexa and you are approaching for a guided biopsy, you are violating that peritoneal cavity. So getting a tumor tissue is not easy as an adnexal mass. That's why the discussion is very important. You have to assess whether it is going to be malignant or benign without getting that tissue biopsy. So how to differentiate an adnexal mass, whether it is benign or malignant? So history and clinical examination we have done, and the tumor markers is important. Also the image USG is the first and most important imaging modality, and you can add CT or magnetic MRI to add on to the USG finding. So the common tumor markers is AFP, LDH beta HCG for the GCT, and CA120 for the ovarian epithelial tumors, and inhibin for the granulosa cell tumor. We know that all these tumor markers are very non-specific and it's not going to help beyond a point. So, but this has some value during the diagnosis and also in the follow-up. So the tumor markers evaluation is very important. See that the USG features of some benign. This is a follicular cyst. I'm not dealing with all these things, and radiologists can surely say that in this transvaginal ultrasound there is a well-defined anechoic lesion, and it is of a follicular cyst. And hemorrhagic ovarian cyst as a typical findings are there, thin septations are there, and also dermoid cyst. Radiologists can see some hairline, etc. So what I want to tell you that some benign lesion, your radiators specifically can confirmatory, they can say that in USG this is going to be a benign lesion. So some lesions can be confirmed by USG itself, by the radiologist. So this is an endometrioma. So some of the benign lesions we can diagnose from the USG itself. So the dilemma is over. But sometimes there are some suspicious features, concerning features for the malignancy in USG. So what are that features? Like bilateral adnexal masses, complex masses, especially when there is a solid component or majority of the component is solid, or there's a mural nodule, or there's a sick septations, or premenopausal patient with a complex mass that persists or grow even after a period of a small observation period, or postmenopausal patient with a simple mass larger than 5 cm or complex mass of any size, and masses associated with the elevated tumor markers, or the patient is symptomatic, or there is an adenopathy, ascites, or peritoneal. All these are concerning features. So in next my slides, I am going to tell you about these concerning features in various classifications are there, various assessments are there. So what we are dealing is, what are the concerning features in image modality? That is how we assess the adnexal mass. So there is an RMI score, risk of malignancy index score. What does it include? It is a mathematical calculation. U into M into serum CA 125. U means it is a USG features. In ultrasound, there is a 3 scoring system, 0, 1, 3. We know that there are these concerning features like multiloculated ovarian cyst, solid component, bilateral lesion, ascites, and intra-abdominal metastasis. If there are no concerning feature, that is 0 point. If there is a 1 concerning feature, that is 1. And if there is a 2 to 5 concerning feature, that is 3. That is the ultrasound scoring 0, 1, 3. And if the patient is premenopausal, she is marked as 1. If postmenopausal, that is 3. And the value of the CA 125. So, for example, if the patient is a postmenopausal patient, it itself is 3. And the ultrasound having some 3 concerning features, it itself is having 3 to 3, 9. And even if the tumor marker, the CA 125 is 30 or 40, she is going to be a high risk patient. So, if that RMI score is more than 200, this is going to be highly suspicious for a malignancy, so better refer the patients for a specialist center for an oncologist. That is the role of this RMI scoring system. So there is an IOTA Sybil rule, that is International Ovarian Tumor Analysis Consortium. What I have made that USG, I already mentioned that there are so many concerning features in the USG, but the specific scoring system is not there. But in IOTA rules, they made into a specific group, M category and B category. M means malignant, suspicious for the malignancy, and B for suspicious for the benign. There is M1, M2, M3, and M4, M5. M1 is irregular solid tumor, M2 presence of ascites, M3 at least 4 papillary projections, irregular multilocular solid tumor with the largest more than 10 centimeter, and very strong blood flow. That is the Doppler study. So it's all the same features, same concerning features. They are categorized into particular risk scoring. And B1, that means unilocular, cystic, presence of acoustic shadowing, and multinocular cyst, all of them are less than 10 centimeter, and B5 is no blood flow. That's having score 1. So based on this M feature and B feature, you can say that whether the tumor is malignant or not. If only B features are there, it's simply a unilocular cyst with no blood flow, that is going to be a benign cyst only. So you can make it B, only B features are there, it is going to be a benign tumor. Only M features are there, it is going to be a malignant tumor. If both of them are there, it is inconclusive, again we need evaluation. So this is a benign feature, unilocular, B1, B2, B3, we know that. So that your radiologists can easily diagnose all these things. And these are the malignant features concerning solid component, thick septations more than 10 centimeter, and high blood flow, that is scoring 4 in Doppler. So based on this, there is a mathematical calculation, online calculation. You can simply fill all these things, whether it is B1 that is absent. In this category, only the B4 and B5 is present there, and no M1 features are there. So after this calculation, the risk of malignancy is only 0.9%. That means it's going to be benign only. So this is a mathematical online calculator. So the issue here, only the USG features are encountered in this calculator. But we know that it's not only the USG finding, it is the patient's clinical features also. Whether she is postmenopausal patient, is there any symptom, what are the tumor marks, all are important. So we have to include all these things. So there is another mathematical calculation model, that is IOTA Adnex model. The most preferred calculation model, I think it is the IOTA Adnex model, because it includes the ultrasound findings, the menopausal status, and the age of the patient, also the tumor markers. And they can easily calculate, means the tumor can be, adnexal mass can be evaluated and categorized into whether it is benign, borderline, malignant, even if it is malignant stage 1 or 2 or 3 or 4, or if it is metastatic like that, they can categorize the patient. So this is the IOTA Adnex model. Again, it's an online calculating system. Here we can feel that I have filled a 65-year-old patient. She is evaluated in the gynec oncology center with a large solid lesion more than 13 centimeter, with a diameter of the largest solid part 5 millimeter, and CA125 is 1.17. After calculation, this patient got a chance of malignancy 33.6%. So we can assess that this lesion is going to be malignant more than 30%. She needs a surgery definitely. In the same calculator, all the features are there, but I just changed the age of the patient into 40. So if the same adnexal lesion in a patient with 40 premenopausal age, the chance of malignancy is going to be just 25%. The other one was 35%. So this is how adnex iota model is calculating the risk. So it is having more importance because it is calculating, it is including both the USG features, the menopausal status, and also the tumor markers. So after that, ORADS has come out. That is like the BIRADS or LIRADS and PIRADS. The ovarian reporting system is there, ORADS, based on again the USG features. They are calculated into ORADS 1, 2, 3, 4, and 5. 5 means 15 to 100% chance of malignancy is there. Definitely she needs treatment immediately, and that too in the specialized center. And ORADS 4, it is up to 10 to 50%, and ORADS 3, it is less than 1% only malignant chance is there. So these are the category. Again, the same features, whether it is solid, cystic, larger cyst, tumor nodule is there. Based on that, it has calculated into ORADS 1, 2, 3, 4, and 5. I'm not going into the details. So if it is ORADS 3 in USD, there is a scope for doing MRI and again there is a ORADS MR calculator. So you can calculate the risk of malignancy by the MRI also if it is ORADS 3 in the USD. So again, there is a mathematical online calculator. You can add all these things. Like if there is any peritoneal nodule or ascites, it is directly going to be ORADS 5. So based on the MRI features, you can just fill it in the online, and you will get that the percentage of this is what is the ORADS category and what is the percentage of chance of malignancy. So finally, the management of an adnexal mass is based on the age of the patient, menopausal status, and the clinical findings and the imaging findings, and the patient decide whether she needs a fertility preservation or not, like that. So, since the prognosis of the carcinoma of the ovary, fallopian tube, or peritoneum is very worse, unless the disease is treated at an early stage, it is always better to have a over treatment. That's a dictum in adnexal mass, because if it is not dealt in the early stage of the disease, that is going to be worse. So the over treatment is the dictum now, or the practice. So in a premenopausal patient, we know that after the ORADS category, if it is 5 or 4, better go for surgery, and ORADS 5 has to be treated in a specialized center. If it is ORADS 4, you can wait for a short period, maybe 6 weeks and 12 weeks, you can reassess the patient with the tumor markers and the USG. In ORADS 3, etc., you can reassess the patient after 3 to 6 months, like that. This is how a flow chart is there. In a postmenopausal patient, you have to more towards the surgical part in the initial itself. ORADS 4 can be directly operated. So for a simple calculation, if your radiologist is so good that they are reporting ORADS, etc., they are calculating online model and giving you directly, it is easy to decide. But if it is not there, the ORAD system is not there in your USG report, the simple thing is, if it is more than 10 centimeter, better treat the patient. If it is less than 10 centimeter and more than 5 centimeter, you can have a wait period of 6 weeks to 12 weeks, evaluate that patient, follow up that patient with the tumor markers. Still, if it is progressing or if it is not stable, you can operate or you can decide on treatment. So adnexal mass in the another is in the pregnancy. The problem in the pregnancy, we know that the tumor markers are very non-specific. It becomes even more non-specific and worse in the pregnancy. The issue is CA120 is normally elevated in the early period of pregnancy and just after the delivery. AFP may be elevated during the Down syndrome or any neural tube defect. LDH is going to be elevated in HELLP syndrome and eclampsia. And inhibin normally produced by placenta cannot be used as a tumor marker in pregnancy. And beta CT cannot be used, CT scan cannot be used. These are the problem with the pregnancy, and we have to. The issues are we have to deal whether it is going to be benign or malignant. We have to deal whether it is going to be asymptomatic. We have to deal. It will affect the growth of the baby. That also to be dealt. These are the issues during the pregnancy. So the dictum is, if it is symptomatic, they have to come out, and if it is going to be malignant, again the treatment plan is the same. If it is an asymptomatic tumor and it is a small tumor, you can wait. If it is a large tumor, it is going to be hinder the uterine enlargement, then that has to be come out during the second trimester of the pregnancy. So during the childhood, they're exactly the same flow chart, but you have to be more cautious that can be a GCT. So the tumor markers has more value when it is in the childhood. So, in a conclusion, the indications for a adnexal mass surgery, if the ovarian cystic structure is more than 5 cm and observed for 6 to 8 weeks and it is again increasing, better go for surgery. Any solid ovarian lesion, better go for surgery. Any ovarian lesion with the papillary vegetations on the cyst wall, any adnexal mass more than 10 cm, even if it is that cystic, and ascites, palpable adnexal mass, or torsion or ruptured cyst or any symptomatic tumor, better go for surgery. This is not the protocol. This is just a simple method to assess the adnexal mass. And laparotomy or laparoscopy, if it is a small tumor and the chance of malignancy, risk of malignancy is very low, you can go for laparoscopy. Again, make sure that it's not spilled out during the laparoscopy, that's all. And when to refer the patient, if there is a high suspicion for the malignancy, better refer to a specialist center. That is like some referral guidelines are the American gynecologist organization, like CR125 more than 200% of ascites, evidence of any distant metastasis, any family history of and high risk of malignancy, that's all. So these are the some guidelines when to refer a patient to a higher center. So thank you.
Thank you, sir.
It was a very good talk. The adnexal masses have always been a matter of concern for us, and we are always confused when we come with adnexal masses. You have clarified a lot of points on how to evaluate them, and now the topic is open for discussion.
Dr. Abdullah is a very clear, precise concept on adnexal mass. Issue is everything depends on ultrasound. Everything is going to ultrasound assessment.
Yes, sir.
So
Actually,
whether purely on ultrasound, clinician has any role, or you have got MRI has any role, how to proceed to MRI if you need, because in clinical practice, majority will go to MRI. Once you are adnexal mass, directly to your cyst, within next investigation they are writing MRI.
yeah, sir.
We have seen many MRIs with
Actually, the first and the most important imaging modality is USG. If the radiologist is reporting the USG in a proper way, and if they are giving all the details, whether it is solid, cystic, septations, what is the thickness of the septation, is there any nodule, is there an ascites, etc. If they are reporting in a good way and in a ORAX way, MRI is not at all indicated. And for the further evaluation of the patient, what I think CCT, abdomen and pelvis will be better to see whether there is a nodal metastasis, is there is any other peritoneal disease, and the upper abdomen disease, it will be better. Because MRI is not needed to characterize that lesion if it is assigned to malignant or benign by the USG itself. If the USG is saying that
USG may be difficult to interpret by population.
yes, as of now, what they are saying, ORAX 3 category USG, that means large cystic lesion, more than 10 cm without a solid nodule, without a septation, it will be difficult. It is ORAX 3. So even a larger cystic lesion may be a malignant. So in that scenario, there is a role for MRI as of this Radiology Association protocol. I think that's true in clinical practice also. Otherwise, MRI is not needed.
Do you give any importance for the family history?
Definitely, if there is a family history diagnosed, this is for the normal patients or normal subjects, not for the high-risk patients. If it is a high-risk patient with a BRCA mutated family or just a high-risk malignancy history, then we have to be a little more towards the treatment side. That's the thing.
Again, the other issues, laparoscopy. Again, everybody, usually in practice is ovarian cyst, solid lesion. Usually, especially in premenopause or early age.
The issue, there is not definite guideline for that, but early age and the chance of malignancy as of this calculator is low, we can still go for a laparoscopy. Make sure that there is no spillage. So it should be a good laparoscopist should do the surgery. There should not be any spillage, and it should be a smaller size lesion also. Then only we can go for laparoscopy. If there is any suspicion for malignancy, means moderate to high suspicion for malignancy, laparotomy has to be done. That should be a full laparotomy with a full staging to be done.
So how to prevent spillage? Is it a really laparoscopy is always spillage is common?
Yeah, laparoscopic extractor bag is there. We can aspirate during the laparoscopy. That can be done if you are good enough to do that. That's all. That can be done. There is no protocol like that. Should not do laparoscopy in a cystic lesion like that. But we can do, but make sure there is no spillage.
Again, to assess the biopsy is again difficult here.
Yeah, assessing the biopsy is very difficult.
So, who the surgeon also feeling difficult because get done as laparoscopy, the later on reports come as.
Yeah, that's why the topic is important. We know that it is a simple adnexal mass. There are even complicated lesions we are seeing in the rectum, everywhere we are seeing, but the discussion is not up to this. The adnexal mass evaluation is a very complex topic. It more than a complex mass, it is a complex topic to discuss. Because we cannot go and just do a biopsy, guided biopsy, we cannot do. It's going to make the lesion 1C3 and going to have the chemotherapy unnecessary like that. So many issues, and that's why there's always a topic like adnexal mass evaluation. We now see that the rectal mass evaluation, we don't say, just go and take a biopsy, that's all. So that's why it's very difficult to deal with clinically and by imaging. Yes, sir.
I think in the last few years I've never seen an ORATS report in any ultrasound. I've never seen it in
Yeah,
any
we only look at ORATs. We just see that USG and we just calculate whether there is a solid, whether there is a. That's why now only I came to know that there is a ORATs online calculator. You just enter into that calculator. They will show you what's the percentage of malignancy.
My question is, instead of MRI, would you prefer a PET scan? To
PET
get
scan,
more
yeah.
information.
Once you think that there is a high chance of malignancy, then next thing, anyway, we have to take that specimen and go to the pathology. So the part of the diagnosis is there. But now what we need is the staging modality. So if you are doing that surgery, we have to get that staging before the surgery, whether there is any lesion elsewhere in the body. So there's either CCT thorax abdomen or PET. Just to characterize the lesion you are asking.
Prior to the biopsy.
As of now, there is no data to say that the PET CT can characterize that lesion. We can say that if there is an enhancement, there may be malignancy like that, but I didn't see.
If the PET scan does not show uptake, it shows no perfectly benign, would you still go ahead and do a surgery?
No. The many of the lesions may be mucinous, so PET scan may not show any uptake in the mucinous malignancy. So PET scan, as of now, it's not a standard of care. You can do that, may contribute. I think Salam sir can.
PET scan cannot differentiate between benign and malignant. Only you can say the characteristics of the lesion with associated finding. A lot of physiological uptake can happen in ovarian adnexal masses related to the menstrual cycle. So it's very important to get into full details. We also don't see, it's not a plus or minus report, whether it is positive or negative. We see all the associated history, clinical findings, and especially menstrual cycle irregularities. But we can characterize, we need all the details into account.
Yes. So what I can conclude that after USG, if you want to characterize that ovarian mass, better go for an MRI if you don't need it, not the PET CT. Yeah.
Are there any comparative studies to say which model predicts it better? I have heard of the Roma model also.
What I could find that is iota simple rule that is having a sensitivity value of around 92% and specificity of around 92%. That's all I can find in the literature, but there won't be a direct comparison. We know that all of them are going to be just helping tool only, not confirmatory. We have to get the pathology, that's all. So if there is a high suspicion of malignancy, we have to take that lesion out, that's all. Yeah.
So I just wanted to add some point. I'm Dr. Yashmi, the joint radiologist. So coming to ORATs, the basic thing for ORATs is the criteria prefers a transvaginal ultrasound to be done to give the final ORAT score rather than a transabdominal ultrasound. So there are a certain criteria for doing transvaginal, like we cannot do it in sexually inactive women, and in obese women the ORATs has criteria for thickness of the septations. The color scoring has various scores. So probably one reason why we do not get a final ORAT report in everything is because we do not do a transvaginal scan and we end up doing only a transabdominal scan. So in patients who cannot undergo a transvaginal scan to get a ORAT ultrasound score, it will always be better to subject them to MRI. And as Sir said, rather than PET, it is MR which will give us a better tissue characterization and it will help us in differentiating the tissues. See, something as simple as fat versus solid tissue, depending on diffusion and T2 stir parameters, etc. That
Uh,
is one point.
Point is well taken, but I'm sure that that's not the reason why it's not reported. That particular group of patients is very small. The unmarried girl sending for an awareness evaluation and obese lady sending for evaluation is very small group only. So you can very well do a transvaginal ultrasonography and report borax. So it is a newly reported system and not that common, and the regulars may not be exposed to that. That may be the reason. I'm not contradicting. But I think it will come as well, because BIRATS is the common. They are just every center is reporting the BIRATS. So maybe next one or 2 years they will report the RATS also.
Thank you, Dr. Abdullah. That was a very interactive session. I think many have many questions. You can approach the speaker after the session.
Thank you, ma'am.
Thank you, sir. That completes our second session. Now, to hand over the memento, may I request Dr. Jishana to kindly hand over the memento to Dr. Sajid Babu. Dr. Hanuman sir to Dr. Rakesh B. Requesting Dr. Elizabeth Joseph and Dr. Nouri Khalid to hand over the memento to Dr. Abdullah KB. Requesting Vice Dean Dr. A.P. Kamat sir to hand over the mementos to our dear chairpersons. Dr. Jishana, Associate Professor, ENT, DMMC. Dr. Hanuman Professor, General Surgery, DMMC. Dr. Elizabeth Joseph, Head of the Department OBG, DMMC. Dr. Nouri Khalid, Consultant Gynecologist, Fatima Hospital. Thank you, ma'am. Thank you, sir. Kindly requesting everybody to register for the quiz competition, which will be held in a few moments later. Moving ahead with our third session, to chair the session, may I request Dr. Sara Chandi, Professor, Department of General Medicine, DMMC, Dr. Wasif Mayan, Assistant Professor, Department of General Medicine, Dr. Yashaswini K, Assistant Professor, Radio Diagnosis, Dr. Kolapur Sir, HOD, Pathology. Welcoming our first speaker, Dr. Keshavan M.R., consultant in pediatric hemato-oncology, graduated from Madurai Medical College and pursued fellowship in pediatric hemato-oncology and BMT from Apollo, Chennai. Over to you, sir.
Welcoming Dr. Keshavan to enlighten us on the intricacies of bone marrow transplantation.
Thank you, ma'am. Thank you for giving me this opportunity. At this juncture, I want to tell you that in Aster MIMS, we have completed over 75 bone marrow transplants, and over 50 transplants has been done in the last 2 years. So, moving on to the topic, it's about hematopoietic stem cell transplant in children. An overview. So, my topic will cover about an introduction to transplant, history of BMT, what are the source of stem cells, what are stem cells, indication for BMT, what is the transplant process, complications, and follow-up. So, what are stem cells? They are just a population of cells which divide for an indefinite period of time. The stem cells will continue to replicate. They have self-renewal capacity, and they can give rise to specialized cells. So, this is what is stem cells. When you look at the type of stem cells, we need to understand that after the fertilization of the egg with the sperm, when we have the 4 to 8 cell stage, which is called as the totipotent cells, where the cells in this stage can give rise to any other cells of the body. And what we are going to talk about is the pluripotent stem cells, our hematopoietic stem cells, which gives rise to just the blood forming stem cells. It gives rise to the cells of the blood components. So, as seen in this picture, the hematopoietic stem cells begin during the embryo development. It is present in the bone marrow and in the umbilical cord. And these stem cells express what is called CD34 on their surface and give rise to all the blood forming cells throughout our life. So, we have the multipotent hematopoietic stem cells, which gives rise to 2 major components. One is the myeloid component, another is the lymphoid component. The lymphoid component give rise to the different lymphocytes, whereas the myeloid progenitors can give rise to our red cells, it can give rise to our platelets, as well as the other white blood cells like the basophils, eosinophils, neutrophils, everything. And he is considered to be the father of the bone marrow transplantation, who had a Nobel Prize. And he also conducted the first successful umbilical cord blood transplant in 1987 for Fanconi anemia. So, the common terminology is bone marrow transplant. That is the older name, which is now replaced by the new concept called as the hematopoietic stem cells. Because the source of stem cells can be from the bone marrow, can be from the peripheral blood, can be from the cord blood. So, there is a small change in the terminology of the transplant services. So, what are the different types of transplant? We can classify them into autologous transplant. Autologous transplant is the patient is receiving their own stem cells, which are initially removed from the body, cryopreserved and given back to the body. Or we have what is called as the allogenic transplant, where the patient derives the stem cells from another person. It can be family members, which is related. Family member means child, siblings, parents, or it can be an unrelated. In the allogenic transplant, it can be a full match transplant or it can be a haploidentical transplant. As you look at the curve, the indication of haplotransplant, where either definitely parents or the children will be a half match, the indication, the frequency of haplotransplant has increased, especially after 2015. As already mentioned, there are 3 possible sources of stem cells. You have the peripheral blood, the bone marrow, as well as the umbilical cord. Bone marrow, which is mentioned in the blue line, is the oldest form of stem cells, right from time immemorial, from the 1950s, 1970s, 1980s. It is steadily in the same rate. If you look at peripheral blood stem cells, it is increased tremendously over the last 2-3 decades. All the transplants which we have done in MIMS Calicut is all peripheral blood stem cells. And you can see the cord blood transplant, which is in green color. There was an initial rise and then followed by a plateau. So the cord blood transplant is also now gradually being phased out. So for which all patients do you do a bone marrow transplant? There should be some indications. So hematopoietic stem cell transplant, for allogenic transplant, there are indications like you have a red cell disorder, you have a white cell disorder, you have a platelet disorder, or you have a defect in the origin, that is in the stem cells. In red cell disorder, we can do for hemoglobinopathies like sickle cell anemia, thalassemia, Diamond-Blackfan anemia. White cell disorder is a diverse background. You can have a benign condition, that is a non-cancerous condition, as well as a cancerous condition. We have primary immune deficiency, severe combined immune deficiency, Viscott-Aldrich syndrome, severe congenital neutropenia, HLH, some of the benign conditions, and malignancy, as we know, most of the relapsed ALL, refractory acute myeloid leukemia, CML with blast crisis, juvenile myelomonocytic leukemia, Hodgkin's, non-Hodgkin's lymphoma, myelodysplastic syndrome, high risk, are some of the disorders where we do transplant. Platelet disorders, we have Glanzmann thrombasthenia. Some of the metabolic disorders also we do hematopoietic stem cell transplant, especially in Gaucher's disease, mucopolysaccharidosis, adrenoleukodystrophy, and metachromatic leukodystrophy. Why we do, what is the concept in these metabolic disorders is, the Gaucher's and LPS, they have enzyme defect. The donor-derived hematopoietic stem cells will give rise to the monocytes, which becomes the macrophages, which will start secreting their enzymes, and this will be taken up by the recipient cells. Same thing also with the metachromatic leukodystrophy and adrenoleukodystrophy. But what we need to understand is these brain disorders, generally it is a genetic disorder. One is X-linked, another one is autosomal recessive. What happens is the first child will be definitely affected. We need to screen the younger child so that even before they develop symptoms, the transplant has to be done. So once a child has the full clinical manifestations, transplant will not reverse. So that is very important in this. And if the stem cell itself is defective, the origin, the source is defective, then you do transplant, like aplastic anemia and the bone marrow failure syndromes like Fanconi anemia. If the stem cell, if the microenvironment, we have the bone, the space inside the bone marrow, if the space is very narrow, for example in osteopetrosis, we know that bone is continuously remolded between the osteoblast and the osteoclast. Osteoblast is bone forming, osteoclast is bone removing. If there is a defect in the osteoclast, more of bone will be formed. There won't be any space in the microenvironment. The hematopoietic stem cell transplant, the donor-derived monocytes becomes the osteoclast, which will help in creating the space. So that is the reason why transplant is useful in osteopetrosis. So these were all allogenic transplant, where we need a donor cells for transplant. In case of autograft, the concept is completely different. The purpose of autograft is to deliver very, very high dose of chemotherapy. When you give high dose of chemotherapy, stem cells will get destroyed, as a result of which the patient will become profound neutropenic and will never have a count recovery. So what we do in autologous is, the patient own stem cells will be collected, will be cryopreserved in the freezer at minus 80 degrees Celsius. We deliver the high dose chemotherapy and the patient own stem cells will be given back. So in children, the commonest indication is high risk neuroblastoma. Other indications are Hodgkin's and non-Hodgkin's lymphoma. In elderly patients, it's the multiple myeloma, and other solid tumors when they are relapsed, like refractory germ cell tumors, medulloblastoma in children. They are all indications for autologous transplant. If you look at the indication for transplant, the commonest indication is myeloma. Myeloma occurs for a major chunk in hematopoietic stem cell transplant. You look at the colors, the green color is autologous and the blue is allogenic. As you can see, myeloma is always autologous. Only a very few cases may need allogenic. Acute myeloid leukemia, acute lymphoblastic leukemia, MDS, aplastic anemia, all these conditions will require allogenic transplant. The Hodgkin's lymphoma is a combination of both, but majority is autologous transplant. So some conditions can have either autologous or allogenic. Some conditions it is only allogenic. Some conditions it is majority autologous. So commonest, as we need to understand is the indication is myeloma. So what is the transplant process? When we look at the allogenic transplant, patient is important. At the same time, donor should be important. First is the patient and donor evaluation. We have to collect the stem cells. Cryopreservation in case of an autologous transplant, conditioning of the patient. We have to give high dose chemotherapy plus or minus radiotherapy to destroy the existing stem cells remove the lymphocytes so that the body will be able to take in new stem cells, stem cell infusion, and the recovery phase. There is something called as the HLA system, the human leukocyte antigen system, present in chromosome 6. There are 5 antigens A, B, C, DRB1, DQB1, one from each parent. So multiplying the two, there will be 10 by 10. When you say a full match in an allogeneic transplant, the patient and donor should be 10 by 10 full match. There is a 25% chance that the child will have a sibling as a full match donor. What is half match? 5 out of 10 up to 9 out of 10. 5, 6, 7, 8, 9 out of 10 is a haploidentical stem cell transplant. Invariably, parents of the children will be a half match. That we need to understand. If we don't have a full match, there are many registries available like Datri in our country where we can have unrelated donor availability. So I already mentioned there are 3 sources of stem cells. This is the first source, which was a traditional bone marrow harvest. Patient will be in the operation theatre under general anesthesia in the prone position. Multiple punctures will be done in the posterior superior iliac crest and stem cells will be directly collected from the bone marrow. One thing we need to understand is, we give high dose chemotherapy, count will become 0, infuse the stem cells. After infusion of stem cells, the recovery will take 3 weeks after bone marrow harvest. Peripheral blood stem cells. The concept is, there is something called granulocyte colony stimulating factor. We give for a high dose for 5 days. So the stem cells in the bone marrow will be mobilized into the peripheral blood and we can collect it through the apheresis machine. It's a very simple process and the engraftment, if you see, is 2 weeks. We need to understand that in the era of multi-drug resistant bacteria in our country, the duration of neutropenia is 3 weeks for bone marrow harvest, it is 2 weeks for peripheral blood stem cell. Every day increase in the prolonged and profound neutropenia is an increased risk for superbugs in these patients. Umbilical cord blood. This was latest, which came after 2012 in our country and it got phased out by 2017. Why? Because umbilical cord blood, the source of stem cells is very minuscule. And the stem cell dose also will be very less and engraftment will be very delayed. 4 weeks a patient is with a 0 count in a transplant unit, especially in the era of superbug, is very difficult. So, as a result of which, cord blood transplants has been phased out in our country. So, the first step is a conditioning process where we give chemotherapy. Patient has to be kept in a special room, isolated room with HEPA filter, positive pressure ventilation. What does this chemotherapy and radiation therapy do? If it is a cancer, eliminate the malignancy, suppress the patient's immune system because otherwise the chance of rejection will be high, and also create a space in the existing bone marrow. The chemotherapy can be very high intense or it can be very gentle chemotherapy. Conditioning like malignancy, ALL, AML will need intense chemotherapy. Where the bone marrow is already weak, like Fanconi anemia, aplastic anemia, we need to give gentle chemo. Children like immunodeficiency, they have only no lymphocytes at all. We have to give gentle chemotherapy. So that also varies between, and of course the comorbidity status. An elderly patient, we need to give a gentle chemotherapy. We may need to modify the medications based on the renal function and liver function test, cardiac function test and all. So this is, some regimens are used for immunosuppression in allogenic transplant, some are used for myeloablation, some can be used for both. So these are just some of the medications which are being used in transplant conditioning. So this is the, if you look at the, this is the increase in the intensity of conditioning regimen. BU-TBI, this was the earliest protocol, 1950s and 1960s, where most of the patients had severe side effects. So the one on the top is the most intense regimen and one on the bottom is a very gentle regimen. So based on the patient's clinical condition, we can alter our chemotherapy accordingly. Transplant is not a surgical process, it's just a medical process. You give high dose chemotherapy, destroy the immune system, and the stem cells which we have collected, we just transfuse it like any other blood transfusion. This looks like PRBC, but it is not a blood, it is a stem cells which is collected and it is given through the central venous catheter. Now comes the most important phase. After infusing the stem cells, the count is 0. There needs to be a dedicated nursing care. 1:1 care will be there. central line care, neutropenic care. These patients are very unique. They behave differently. We need to monitor for fluid retention, weight gain. They will have severe mucositis, loose stools. They will require morphine infusion, fentanyl infusion. They will need total parenteral nutrition. All blood products must be leukodepleted and irradiated. So pain management, mucositis care, and medications to prevent infection as prophylaxis is mandatory. And after 2 weeks in a peripheral blood stem cells, the counts will start recovering. And when the neutrophil count crosses 500 for 3 consecutive days, we say the patient has engrafted. And sometimes BFT can fail also. Not everything is a success story. Autologous, the chance, because it is a patient's own stem cells, the chance of failure is very less than 1%. In a full match, the chance of failure is less than 5%. In a half match transplant, because of the mismatch in the antigens, the chance of failure is as high as 15%. So when the graft failure occurs, the complications will be even more because the patients are profoundly neutropenic. Already they are neutropenic for 1 month. We may need to salvage them with a second transplant, provided they have the children or the adult have not acquired superbugs. So that is one thing, which is one of the terrible complications of transplant. And they have unique complications post-transplant, like the donor cells can attack the patient cells. It is like a marriage. If the husband and wife are happy, the marriage goes happy and smooth. So you can have graft versus host disease, you can have graft rejections, unique infections. If it is a cancer, you can have relapse of the disease and unique organ toxicity. This is a very nice slide where the different types of complications that can be seen post-transplant. First 30 days, where the neutropenia is there, WBC count is 0, they have a central line in situ, they have highest risk of bacterial infection. You can see that the gram-negative bacteria, throat, streptococcus, these are the commonest. Fungus, Candida being common because of central line and mucositis. Once the count improves, after 30 days till 100 days, though the WBC have improved, the lymphocytes will take minimum 3 to 6 months for recovery. So during that time, we have more of fungal and viral infection. So even though the transplant becomes a success, it will take minimum 3 to 6 months for the complete immune reconstitution. So that we need to be vigilant in that. So they need to continue the antiviral, antifungal prophylaxis accordingly. No vaccines should be given to them. They should not travel anywhere, not go to any crowded places till 6 months post-transplant. So once the transplant is a success, we have to follow them up. Initial 12 weeks, we say 100 days. The parents, the family should be within 2 to 3 kilometers of the hospital radius wherever they are undergoing transplant. Bi-weekly OP visits. Immunosuppressions we give for these patients. Unlike solid organ transplants, they don't need lifelong immunosuppression. Generally by 1.5 years, most of the immunosuppressions will be tapered off and stopped. So during the initial time, we need to monitor for the immunosuppression levels, either Pangraph, cyclosporin, they need to monitor. Monitor for viral reactivation. It's preemptive viral reactivation as the immune system is very weak. So we look for the CMV, adeno and EBV virus by PCR technique. And even if the BMT is success, after the counts improve, we take sample from the patient and see whether the patient cells are there or donor cells are there. It's called chimerism. We need to have more than 95% donor DNA to call it as a success. Even if the first count, the day plus 15 is 100, we need to serially look for any drop in chimerism. And we need to monitor for GVHD, and personal hygiene is very important. And then we space out for late effects because these are all very high dose chemotherapy and radiation therapy. We need to monitor for their height, weight, monitor for BP, liver test, kidney test. Some patients can have kidney injury and can develop acute kidney injury or CKD. Incidence is less than 1%. We need to monitor for late effects, chronic GVHD, look at the ophthal, and especially for developing children. Older protocols had busulfan based regimen. I had initially mentioned bucite TBI, where the infertility rate was closer to 80%, which is permanent. So we need to monitor for all these things. But now latest drugs have come where the incidence of infertility is comparatively lesser. And we need to look for second malignancies because they have received, especially if it's a cancer patient, they have received multiple lines of chemotherapy. And we need to monitor monthly once in the first year, then once in 3 months, then space out 6 months for the next 3 years and yearly thereafter, especially to monitor for the late effects. So to conclude, transplant is curative for both benign and malignant conditions. There are advances, especially in haploidentical stem cell transplant, and it's a multidisciplinary team which involves the transplant physicians, nursing care, supportive staff. We need to have adequate ICU support, both the pediatric and the adult ICU if we are doing high-end transplants, and a dedicated FRSS lab with blood product support and all in-house facilities to be available. Thank you.
Thank you very much, Dr. Keshavan, for a very informative session on hematopoietic stem cell transplant, which involves both malignant conditions like lymphomas, leukemias, and also benign conditions like hemoglobinopathies, bone marrow failure syndromes, immunodeficiencies, inborn errors in metabolism. You have covered the entire gamut of hematopoietic stem cell transplantation, including all the complications and follow-up that is required in an extensive manner. The floor is now open for discussion. You can ask whatever questions or queries.
Any revaccination?
Yeah, so I forgot to mention that. So all the patients who have undergone transplant, their immunity is zero, and they have got a repopulation of new stem cells. So it is like a newborn baby. So you need to vaccinate them. We start vaccination 1 year post-transplant. Initially, they're killed vaccines. We have a schedule. It is available in the website. And 2 years after transplant, we need to start live vaccines. And the requirement is basically they should not be on multiple immunosuppressants, because some patients will develop chronic GVHD, 2-3 immunosuppressants they might be on. On a single agent immunosuppression with a low dose steroids, 1 year post transplant, yes, we need to start revaccinations. That is mandatory. So that is very important. No live vaccine till 2 years. And another thing is, anybody who has transplanted, they have family members, small children nearby. We should tell them not to, give the pulse polio immunization if they are given to other children or the transplant patient themselves. They may have younger siblings and all. In case they wanted to give the pulse polio immunization, you have to, isolate these patients for at least 2 weeks from the, the contact of the polio. So that is very important. And all of them will till from 1 year to 2 years it's killed vaccine. Post 2 years it is live vaccine that can be given. Yeah, provided they are on a single agent immunosuppression and not beyond.
How is the outcome of the last 50 transplants?
So our transplant, we have done very, very high risk transplants from severe combined immune deficiency from 6 months of age to osteopetrosis to juvenile myelomonocytic leukemia, where the relapse rate is more than 50% and all those things. We have had over 85% success rate we are having. Most of the things are, relapse is one of the major cause of morbidity, which we see, especially when the high-risk cases are taken into consideration. Over 80% we are having, yeah.
What is the very unusual complication you have faced?
So, there was one patient whom I remember last year. It was a case of a myelodysplastic syndrome. She developed what I learned during my 3-year training period. Over 250 transplants, we had a training period during Apollo Chennai. She had all the complications of transplant. She had a primary graft failure, she had a fungal infection, she had a veno-occlusive disease, she had a transplant-associated thrombotic microangiopathy, so many. So it's a very challenging situation, especially when they develop all the complications in one gamut. And one challenging transplant I could think of, another one was an osteopetrosis, a malignant infantile osteopetrosis, a 5-month-old baby. Because osteopetrosis is one condition where you need to do an emergency transplant before they lose the vision in the eye. It was a chubby baby with requiring blood and platelets every 5 to 6 days. We couldn't get lines. So accessing of a peripheral line was very difficult. With the help of the trained nursing staff, some of the senior staffs, we were able to manage. Rejection rate is very high in osteopetrosis. We somehow pulled the baby out. Child had the drop in chimerism, so we need to, I had mentioned the chimerism, you look at day 15, day 30, day 60, day 90, but for these children you have to look even more frequently, stop the immunosuppression, do DLIs, take some more stem cells from the donor, and that was one challenging transplant. There was another kid with severe congenital neutropenia who had a primary graft failure, 6.5 months child, with a huge pus draining out from the eyes because of neutropenia, which was never healing. And salvaged with the second transplant. Now 45 to 50 days post-transplant, doing well. Daily continuous high-grade fever spikes, 103, 104. And we have pulled out patients with inotropes. And one more thing is, we cannot pull these children. We are out of the BMT unit into the either PICU or MDICU at the earliest. We cannot, because there will be an increased risk of cross infection, especially from the viruses which is circulating. So we start early initiation of inotropes we do for these patients because their behavior is completely different. Like the normal pediatrics, we give 20 ml per kg, 20 ml per kg fluid bolus, 60 ml per kg over 6 hours. That cannot be done for these patients. Their heart will pull out. So we have to early initiation of noradrenaline, double inotropes and all we used to do in the BMT unit. Some of these kids will need high flow nasal cannula support, HFNC support, especially osteopetrosis kit, the MDS kit, especially during the engraftment time, endothelitis. So unique things that we do different to general thing is early initiation of inotrope support, use of high flow nasal cannula, but most important thing is nursing care. A patient with a zero count, graft failure, the second transplant with a central line in situ, which was of course will be replaced every 4 weeks, with no hospital acquired infection, and pulling out those children is the main challenge. Because the major chunk of our allogenic transplant is haploidentical. We did the first alpha beta depleted haplotransplant, and that's a special technique in haplotransplant which I didn't go into details. So we did the first alpha beta depleted haplotransplant in entire Kerala. So that is just another word to mention about. And our patient ages vary between as young as 6 months to as old as 59 years of age. So that is one thing. Yeah.
Excuse me, have you encountered any fatal pulmonary complications of hematopoietic stem cell? Because I read about a girl called Aisha, I think her name was Aisha, who underwent bone marrow transplant for subacute combined immunodeficiency. She was a writer or something, and she ultimately underwent some kind of pulmonary fibrosis, long-term complication, and she died.
So it's a very rare complication, especially with the older chemotherapeutic agents like busulfan-based conditioning regimen, or when you use busulfan with cyclophosphamide. They are all age-old protocols, which has now been replaced with latest protocols like triosulfan. They are very rare complications. During my training period also, a couple of children I have seen, our consultants, old follow-ups who developed these unfortunate late complications, and one of the kids actually died when a COVID struck her down because their pulmonary reserves will be lost. So there are unique pulmonary complications also. At present, not at MIMS, maybe after 4-5 years when long-term follow-up comes, maybe some patients may turn out to be there. There are different types like bronchiolitis obliterans, organizing pneumonia, cryptogenic organizing pneumonia, different phases of pulmonary complications are there, where the diagnosis is difficult, treatment is difficult. You need to, some of them you need to titrate immunosuppressants, you need to add certain medications. It is rare I have seen, and they will not tolerate COVID itself. They will die immediately.
So do you recommend any long-term antibiotic prophylaxis? Like I had a patient who died last year. He survived a BMT for 11 years, and he had developed chronic GVHD, and he also developed bronchiolitis obliterans. So I was putting him on that azithromycin 250 weekly thrice regimen just to eliminate the biofilms because of the recurrent respiratory.
No, so that is the FAM therapy, fluticasone, azithromycin, and montelukast therapy. That where we give the azithromycin Monday, Wednesday, Friday. It is basically to reduce the some of the query chronic GVHD, query bronchiolitis in long-term patients. But when you have a chronic GVHD, you will be definitely on multiple immunosuppressants. Unfortunately, when you are on immunosuppressant, your lymphocytes won't be functioning. As a result of which, the normal viral infection like a cough, cold, fever, which may settle in majority of us, the kids may not survive. It's not bacterial, it's mostly, the death could have been mostly viral bar fungi. Because I still remember, we used to have during our training period, emergency phone where the residents used to have patients from all the 1,000 transplant patients will be calling. One patient who has 10 years post-transplant for thalassemia matched unrelated donor. I was having the emergency number actually. He had chronic GVHD on 2-3 immunosuppressant. He developed a loose stools, cold, suddenly he died. So it's difficult if you, they have multiple immunosuppressants and all. We cannot tell them don't go to school for 10 years after transplant. That is one bane in transplant. The chronic GVHD, which nobody can predict who will develop.
The feasibility of TBI in ostomies.
So there is a new concept called, it's not a new concept, it's an old concept only. It's called total body irradiation. So, total body irradiation there are two different indications, in the sense two broad categories where it can be used. One is for acute lymphoblastic leukemia, ALL. If the patient is more than 4 years of age, the international trial, forum trial, because radiation has got a lot of side effects, both acute and chronic, lot of side effects. So the international, the European and the American consortium, they did the forum trial where they divided into two arms. One had a total body irradiation based chemotherapy conditioning regimen, etoposide plus TBI. Another one had a non-TBI based regimen. They found out that the chemotherapy alone arm was inferior by more than 30%. So that arm was stopped prematurely. So for ALL, relapsed ALL or refractory ALL, if the patient is more than 4 years of age, it is advisable to do a total body radiation based conditioning regimen. That is one indication. Another indication is in the haploidentical stem cell haplo setting, where we give total body irradiation. Because I have already mentioned in half match transplant, the rejection rate is higher, 15%, 15 to 20%. Full match is less than 5%. So this total body irradiation will help in immunosuppression also. So these are the two indications where we use the total body irradiation. So agents used for both purpose, both for myeloablation and immunosuppression, we have the total body irradiation. That will be a lower dose single fraction, 2 gray. The standard is 12 gray. So that is one thing. But one drawback is, or the major drawback is, a lot of side effects will be there. Growth will be hampered in children. You'll have thyroid problems, you'll develop cataract, you may develop second malignancies, infertility rate is very high. So these are the things. We have to weigh the pros and cons, but you don't survive by less than 30% if you don't give. Now there is something called as total marrow lymphoid irradiation, especially when you use a proton-based therapy. Rather than me, I would request Satish sir to explain those intricacies where other aspects of the other organs will be spared, and only the hematolymphoid system alone will be where the stem cell niche is there will be destroyed.
Thank you.
Basically, by total body irradiation, we mean using high-energy X-rays to obtain our goal, be it myelosuppression or myeloablation. Whereas total marrow lymphoid irradiation is a much more precise entity where we use protons. Basically, going back to our basic physics, the protons have a peculiar capacity to deposit energy in the desired organ at a given depth even. That means if you have a bone, as we all know, cortex, medulla and the marrow. So it can spare the cortex and deposit the dose in the marrow alone. So the entire body we can plan in such a way the cortex of the bone does not receive, the other organs do not receive. Whereas it is a carpet fire in the case of photon irradiation, X-ray irradiation. It is a much more precise and volume delineated irradiation where we target only the marrow of the entire part of the body. So, which could be, of course, that is the physical side of it and the technical side of it. But cost is extremely prohibitive, which negates the routine use of total marrow irradiation in all the otherwise eligible candidates.
Thank you very much, Dr. Keshwan, for that very exhaustive and very informative session, and also Dr. Satish for that extra insights on total body irradiation. Thank you very much.
I just want to mention a point. Transplant is never a success without nursing care. So all our nurses are actually going for international conferences, doing presentations. So the nurses training is actually, we keep it as a front stage, and we conducted the Marrowcon also, headed by Gangadhan sir. Our nursing was done 3 months back. So nurses training is very important in hematopoietic stem cell transplant. Otherwise, they are the front line. They should know what is there. So they are the ones.
So in our next conference, we'll invite one of the nursing people also to give their valuable insights on nursing care in hematopoietic stem cell transplant. Thank you very much, and we move on to the next.
Thank you, sir. Thank you, ma'am. May I request our next speaker, Dr. Abdul Malik, consultant in radiation oncology, Astorans, who has graduated in radiation oncology from Rajiv Gandhi University of Health Science. Over to you, sir.
Yeah, so Röntgen had discovered X-rays in the year 1895, and just 1 year later in the year 1896, these same X-rays were used to treat a patient with an advanced breast cancer. So Emil Gruby, he was the person to actually experiment with X-rays and the radiation to treat breast cancer with the just simple concept that you can utilize your radiation to break the DNA of the cancer cells. So that was the start of radiotherapy, and over the last 125 years, radiotherapy has evolved to an altogether different level. So I invite Dr. Abdul Malik to give his insights into a brief introduction about the basics of radiation therapy. Over to you, sir.
Good afternoon, one and all. So I'd like to explain exactly what is it that we do in our department, basically how we work, and basically how radiation works, and how we work as a team. So radiation department is not a standalone department. We work together with medical oncologists, surgical oncologists, nuclear medicine, pathology, radiology. We are an integral part of the oncology team with our own sets of technicians and our own staff and our own infrastructure and facilities. So like Sir was telling, so radiation therapy is the use of various forms of radiation. Radiation, people ask what is it? Like basically it's X-rays. What we are using is photons is X-rays. So we use these photons most of the time to treat a specific part of the body for a specific disease. So radiation is a very effective tool, and it has been effectively used for more than 100 years. Most of our patients who enter the oncology department will have some form of radiation therapy being given as a part of adjuvant or curative treatment. Sometimes radiation is all that is needed for a patient for treatment. So when William Röntgen discovered X-rays, Marie Curie discovered radioactivity. So immediately within 2 months, X-rays were being used and they were tried for cancer treatment. But since the technology was primitive back then, the refinement in use of radiation wasn't that good. So as the radiation physics improved, as we got to know more about radioactivity, radionuclides, what were the radioactive elements, and the X-rays which were initially used were low energy X-rays, they couldn't penetrate deep. So they were not capable of destroying the cells in the depth. So once we had a good knowledge of what was radiation physics, what is radiobiology, and combined with the technology, the latest, now we use computer, we integrate it with CT scans, PET scans, we have informatics like radiomics, genomics, all these data put together has improved the field of radiation oncology. So from being a simple superficial X-ray department, which is part of radiology department, to now as a completely different field with subspecialties in it, with different field like radiation biology, radiation physics being a different field inside it. It's a entirely different world altogether, which we are not exposed to during our training days as in MBBS. So what it does, radiation therapy, basically it destroys the DNA of the cells. So this is how the cells get damaged, and later on apoptosis is induced, and once an apoptosis is induced, it goes for cell death, so programmed cell death. It also releases free radicals, oxygen free radicals, so patient who are a part of the body which is properly oxygenated, well oxygenated part of the body is more sensitive for radiation. So radiation is more sensitive during the G to M phase of the cell cycle. So we need to know the exact radiobiology of each cancers, how radiobiology is different for each cancer, different for each organ, how radiation affects each organ, what are the toxicities, how it can be tailored. So when is radiation used? So the best plan for each patient is frequently determined by a team. So we have a tumor board. First we come to the conclusion that the patient is having so and so disease and patient is going to be treated in so and so manner. And then we are going to plan the chemo, the radiation, the surgical aspects accordingly. So multimodality treatment, combined tumor board discussion is held, and the radiation team is alerted for the referral of the case. So people ask, is it safe? Like radiation therapy, how safe is it? So with the newer advances in technology, our computerized planning, and with all the data that we have, the radiation therapy has become personalized for a patient with inputs from all the fields: radiology, PET, nuclear medicine, surgical information. So all this has made our job far more precise and less toxic and bearable for the patient. And is it safe? The toxicities that we see today are intentionally induced into the patient. That means if we see the skin reaction and in the neck or on the breast, that is part of our treatment. So those things we have a control on. When we know, we can predict, we know exactly what is going to happen to the patient on which particular day. The patient will be afraid of all these toxicities, seeing all this burnt skin, but that is intentionally induced as part of the treatment. So why use radiation therapy? To cure cancer as well as for palliation. Sometimes only radiation is needed for treatment, and most of the times it is combined with chemo and surgery. For palliation, it's an excellent tool for palliation because you can basically direct it in any area, in any aspect, and for palliation you don't need to increase the dose. You can commit a very small dose and achieve pain relief. So what happens when the patient is referred? The patient meets the radiation oncology team. So the doctor, the radiation oncologist first goes through all the reports, confirms the diagnosis and the plan for radiation, the possibilities, the toxicities, the side effects, the data which makes radiation relevant, evidence-based decision which was taken is explained to the patient. So the radiation oncologist heads the team. There is a medical radiation physicist, a radiation safety officer. So the medical radiation physicist is in charge of the treatment planning after we decide the volumes of the radiation. The physicist will usually design the radiation fields, the radiation doses is tailored accordingly as the doctor has requested. So radiation physicist's job is a vital job in maintaining the machine to know what is actually coming out from the machine, whether the machine is properly calibrated, whether the radiation plans, whether the radiation that patient is receiving is accurate, and if there are any deviations or variations in the plan, and troubleshooting any basic errors that happens during the course of the implementation of the radiation. Dosimetrist, we don't have a standalone dosimetrist. Our radiation physicist does the work of dosimetrist. Radiation therapist. Radiation therapist is the one who delivers the radiation on a particular day to the patient. They set up the patient on the machine. They make sure the patient is verified, the proper patient is being taken, the proper plan is loaded in the computer, and the proper treatment is being implemented, the anatomy is matched, and the radiation that is going on is safely delivered. So this is the last step in our process, where if it fails, at that point everything fails. All the beautiful plans that we have made on the computer and all the promises that we make to the patient, if we do not make sure that it is not implemented on the couch, on the particular day, on every particular day, in every sitting, then that radiation plan would have failed. Other than this, we have additional radiation oncology nurses who support the patient, gives counseling, and we have physical therapists and supportive teams. So what to expect? Patient is referred, then there is a consultation, simulation, treatment planning process, and the treatment is delivered. So this is the referral. Patient is discussed in the MDT. Consultation with the radiation doctor. The doctor explains why radiation is being done and what are its goals, what is the aims and objectives of radiation. So here the work begins, simulation. So patient usually comes in and asks like, when can we start radiation? We need to do it now and we need to start it tomorrow. So for most of the precise, complicated type of radiation that we deliver in our department, that cannot be done. It's not off-the-shelf treatment that you can get. It has to be tailored for each individual patient's anatomy, each and every individual patient's body, and the need for the radiation differs in each patient. So it's not a one-size-all ready-made treatment that you just can download and display. So you have to simulate the patient, you have to place the patient in the CT. Why the CT? We scan the part of the body which we are interested in. Suppose we are treating a brain tumor. We make an outfit, we immobilize the patient so the patient doesn't have movement and every day's movement is matched on a daily basis. We acquire the scans, we get the image of the patient's brain or the particular organ we are interested in. Once the simulation is done, there are special tattoos or markers or lasers that we use to mark the patient's surface. So reproducibility, the exact site which is needed, that has to be marked. Proper counseling has to be done. Patient has to tolerate lying down on a couch. Patient with an SVC obstruction. Some patients who are very claustrophobic, patients who are not properly counseled, they will not be able to tolerate a tight mask. Young children, pediatric patients, will have to put them under anesthesia to undergo simulation. So they will not cooperate. Patients who are disoriented, patients who are not in the right sense of sensorium, they will not be able to undergo simulation and take in our commands. They will not be able to obey our commands. So giving treatment for them is going to be challenging. So such patients we usually avoid. Children, we put them under anesthesia because they will not cooperate. So then what happens, once we acquire the data of the patient, treatment planning, so we would have studied the entire history, physical examination, the biopsy reports, the PET, the stages, everything that a doctor is supposed to do. And only then, after a proper history, clinical, physical examination, all the reports, everything is gone through, do we go and do the planning of the patient. If we haven't physically seen the patient, we cannot just randomly sit remotely in some part of the world and do the planning on the computer. Like we can do teleradiology for reporting, but that's not exactly possible for a clinical person. So physician, it's difficult. You can do surgery also remotely through maybe your robotic surgeries. We can ask the help of surgeons, expert surgeons outside the country, and they can remotely log in and do it with new technologies. But it would be best not to do that in our case, because radiation planning on the computer, on the CT scans, using all your MRI, PET, all that is irrelevant unless and until you have physically examined the patient. So we map out the patient's cancer. So our treatment planning is an extrapolation of the surgeon's dissection or the surgeon's surgery. Suppose you have a gynec malignancy, you have a cancer of the cervix, a simple case. So we have to identify exactly where the cervix is, exactly where the uterus is, how it moves, where the parametrium, what are the drainage stations, what are the lymph nodes. We need to identify it on the CT, we need to mark it, and we to define the volumes, just like how a surgeon would dissect the patient on table. So these are the extrapolations of what a surgeon would do in the theatre. So we are doing it on a computer virtually with the patient's anatomy and all the information that we have on the CT scans. And sometimes post-operative patients, breast sarcomas, we usually call the surgeons to come in and see our volumes and see the plan so that we don't miss anything. We usually have the surgeons marking, very important for the surgeon to place the clips on the surgical bed, the tumor bed, so that we can identify those areas and it is not missed. So that is the part where we give an increased dose or which is vital, it shouldn't be missed. So the surgeons have to define the surgical volumes while they are doing the surgery so that it's easy for us to give our radiation. And if we have a doubt, we have to call the surgeon and ask the surgeon to define the volumes for us if we have a doubt. Then after that, the plan, the volumes which we decide, that is given to the physicist, and the physicist is the one which makes the plan for the radiation. So we give the doses, prescription, just like how a medical oncologist would prescribe the chemo, we prescribe our radiation, which organ should get how much dose and which organ is at risk. That is, the normal organs should be defined. Suppose you are giving cervix, you need to define bladder, rectum, bone marrow. You need to you need to prescribe exactly how much each organ is going to get. So you need to delineate all those. So the physicist is the one which makes the plan practical and possible, and also verifies whether the plan is going to be radiation plan, the delivery of the X-rays onto the patient, whether that is actually correct, whether that's actually going on correctly before the treatment actually begins. So all the steps that we are going to do is done beforehand and made ready. Nothing is done on the day when the treatment is being delivered. So treatment process, the main thing is the planning, the simulation, and the verification, the quality assurance, whether the exact radiation dose has been prescribed, whether those constraints what we have prescribed is achieved, and whether that is viable or not viable. If it's not viable, again they have to sit and replan. So that all this will take for a good radiosurgery or a good image guided radiation, IMRT, all this will usually take 7 days of working time, because we also have other patients along with this. So treatment process, the patient is verified, patient enters the department, patient is verified, the tattoos or the markings where the patient is marked, that is verified on the couch. Patient is set up, imaging is taken, and the plan which is readied by the computer and the physicist, which is passed by the physicist, which is approved by the radiation oncologist, that is delivered on the linear accelerator. So this is the linear accelerator. You can see the gantry head is like moved here and there. So it delivers the radiation beams in multiple fields throughout, like where exactly where we need. So the couch can move in, couch can rotate, the gantry can rotate. So we can design the angle, the fields, any way which we want. So we have degrees of freedom in which we can put the radiation through the patient's body. So broadly, we define the radiation treatment as external radiation, which is delivered through the linear accelerator, and the internal radiation, which is called brachytherapy, which is placing the radioactive materials like cesium, iridium into the patient's body, into the patient's tumor, directly into the patient's tumor. Like we do brachytherapy for cervix, we place the radioactive sources directly into the uterus. So external beam radiation, again we have various technologies in giving this. Basically the improvement in technology is so that we can spare the normal organs more. The treatment of the tumor is going to be like, that effect is going to be the same. The tumor is going to get the same dose with 3D, IMRT, IGRT. So we are able to deliver the treatment to the tumor. But what happens is, when we give treatment where we have not shielded the organs, the normal tissues, the normal organs end up getting more doses. So the side effect is more. So what is the point of increasing the technology or making the treatment more complicated? It is to spare the critical organs and to deliver as least amount of radiation as possible to the normal organs while treating the tumor properly. So that is why we have evolved and used 3D, IMRT and IGRT. So this is a multi-leaf collimator, you can see, and we can shape it any way we want. So you're treating a parotid here, we can shape it according to the shape of the parotid, and the radiation is going to be delivered exactly as per that shape. So when you combine that with multiple fields around the patient's head, we give a full dose to the parotid while sparing other organs, other critical organs nearby. So intensity modulated is nothing but a 3D printing. You have 3D printers today where we can do a 3D printing. So intensity modulation is basically a radiation printer. It basically imprints or paints the dose of radiation as we define, as per the volume, as per the complicated surgical volumes that we define on a particular patient. So if you have IMRT radiation for a tumor that is near the brainstem, basically paints the surface, paints the tumor in such a way that the brainstem gets a very less dose and the tumor gets a very high dose. So IMRT, IGRT, then you have stereotactic radiosurgery, stereotactic radiotherapy. So basically it is giving a very high dose to a point while sparing the critical organs. So proton beam therapy, as Sir was telling. So what is this proton beam? An atom has electrons, neutrons, protons. Electrons revolve around the nucleus. So if you split the nucleus, you get protons. So basically hydrogen molecule without the electron is the proton. So if you see a balloon moving in this hall, and if it is that's striking the target over there, it's easier to push the balloon and strike the target, but it's difficult to control this balloon. It's a very light structure. So it's going to go around and hit all over, not only the target structure, it's going to hit all around. So that is basically X-rays. You put the X-ray from here, is going to go through and going to come out. It's a very light, it's just a packet of energy, photons. So electron is something like that, it's a very small structure. Proton is like having a very heavy iron ball and then you're striking the structure. But it's easier to control the flow of the proton, where exactly it's going and where exactly it's going to come out. So you're going to put the proton through this part of the brain. You can stop it just short of the brainstem, treat the tumor, and then you can exit. This helps us in sparing the critical organs and treating the normal tissues treating the tumor tissues to a very high level. So just compare it with a simple analogy of a balloon and a metal iron ball, huge metal ball. So it's easy to control the wrecking ball, metal ball which we use, but it's difficult to control hundreds of balloons floating around. Stereotactic radiosurgery for X-rays are used. It has a gamma knife, that is a radioactive source, a cyber knife, that is a photon, that is an electronic source. And we are using linear accelerator in our department to deliver stereotactic body radiotherapy and radiosurgery. It's a specialized form of radiation where we use this penetrating energy and deliver a very high dose to a particular organ while sparing the nearby structures. This is through the computerized planning and the technology that we have. What is internal radiation? So you can see the coin and you can see those seeds there. So those are the sizes of the radiation material, the iridium that we use, the miniaturized sources. So we can implant this anywhere we want in the body as long as it is accessible. So you have a bronchial obstruction, you can put a catheter into the bronchus, define that area and take this. It is attached to a long coil which is attached to a robot. It uncoils itself and this radioactive source goes to that part of the bronchus where we have defined. It delivers the amount of radiation that we have put in the computer and it comes back. So this is a very high energy at a very small area. So we can deliver a very high energy. It is not possible with external beam radiation because we are taking, it's like taking the sun itself inside the patient. So the power, just like you're saying, the power of the sun or something like. So very high dose, more than 10 times or 20 times the dose that we are able to deliver with internal radiation, which is not possible with external radiation. So in effect, the normal tissues nearby, it receives very less dose. So you give half the dose during cervical cancer treatment through external radiation, and then for treating the small disease in the cervix and in the vagina, that small tumor is defined with the MRI or the CT, and then we put the brachytherapy sources, brachytherapy applicators into the uterus, into the vagina, and deliver the radiation to that particular area. So this helps in reducing the side effects, the radiation side effects into the uterus, into the rectum and the bladder. So permanent implants, before we could place permanent implants directly into the prostate. Temporary implants is what we are doing in our department. All this said, we allocate more than 40% of our time for treating the side effects. After treating the patient, main thing is to deal with the side effects. Not as bad as giving chemo, but still we can manage most of our side effects on OPD basis. Very rarely we need to put the patient on IP basis and treat, or very rarely the patient ends up in ICU unless it's some other medical complication. So unlike Keshavan or Dr. Srilesh, we don't end up sending patients to ICU with radiation. So the cancer care team involves all these people. So if you can ask questions, it would be better, because this is just a gist of how we work. And I'm ending my presentation with this slide. Thank you all for your patient listening.
Thank you, sir. Thank you for the wonderful session. Actually, it was like listening to a story of a patient who has just come and how you go around. So it was like we spent a day at your department, and it was presented in a beautiful manner. So if there are any questions, I think we'll take.
The side effects of radiation, we kind of disagree over there. There are significant side effects, especially in head and neck cancer. And most of the patients get admitted under medical oncology because we manage.
Exactly. I think he said this. A beautiful part of the story was mentioned, but then probably I think
we can manage. It's just that we don't have night duty doctors.
So we take care of these side effects.
I think the bad part was conveniently skipped.
No, we are very well capable of treating the toxicities. The thing with head and neck toxicities or mucositis, those things are predicted exactly as we want. I mean, it's like, a chef grilling the fish or the chicken. The chef knows, okay, this is well done, this is medium rare, this is burnt. So when I look at a patient, okay, this is going to be burnt, this is going to be well done, this is going to be medium rare. So, okay, we know this part is going to burn. So in front of Srilesh, I'll be telling the patient, okay, this part of your neck is going to just podinju po. The patient will be like looking at Srilesh, what is it? It's like, nothing will happen. It's like, we'll take care. So that is intentionally done. So the toxicities are part of the treatment. So that is an intentional part of our treatment. Unpredicted toxicities, that is when we have problems. Like patient develops loose stools even with low dose of radiation, maybe hypersensitive. There are inherent genetic conditions where patients are not supposed to undergo radiation. They may be hypersensitive to it. Certain patients with ulcerative colitis or Crohn's disease, we have seen severe loose stools and we are not able to manage those toxicities. Yes, in those cases the patients will end up in ICU or even death. Even death has happened. So we have to be careful, and very rarely very odd cases of radiation deaths can happen. Mostly it is OP basis of treatment. But unless you see all this in the department, it's very difficult to understand exactly what is being presented here.
Excuse me, is there any targeted therapy, like you radio label these malignant cells using something and then you give some kind of targeted treatment for these particular cells, or is there something new like that?
Yeah, the targeted therapy is basically the diagnostics. Dr. Selam does an
I think that will come in the next topic.
So that is a different field. They can radio label and like certain tumors have a certain predilection for certain elements. So that's how we look at it. So radiation is basically very easy to treat the patient, easy to manage the complication, but very difficult to understand exactly what you're doing. It takes 1 or 2 years to understand exactly what is what. Thank you.
Thank you, sir. Welcoming our next speaker, Dr. Selvam Karnati, consultant and HOD nuclear medicine Astamans, who has graduated from Kilpauk Medical College and pursued MD nuclear medicine from AIIMS, Delhi. Over to you, sir.
Anybody can help?
Oh, yeah.
What is this?
Presentation. PowerPoint.
Good afternoon. Straight away going to topic because of time concern. So before starting the topic, two important things about nuclear medicine. One, how we are different from radiology. So radiology, you got the patient and the scanner. Nuclear medicine, we got the third component, that's the radio tracer, what we are going to inject or inject to the patient. So if you got the third component, that's a radio tracer, then it's nuclear medicine. And second thing, nuclear medicine has three divisions. One is PET, and second is gamma or SPECT imaging, and third is the therapeutic component. The most common is for CA thyroid, what we have a radioiodine. So the scope of discussion is wide, but I will restrict my topic only to the basics with one particular modality, that is PET-CT, especially in oncology. So PET-CT, in the year 2000, it was named as the invention by Time magazine, but in India it's famous only after 2010. So why PET-CT in oncology? We have different modalities, but why PET-CT is important in oncological evaluations? Because the threat is known actually because of a lifestyle and everything. The cancer incidence is going to be higher in future. So are we scared of it or we are going to face it? That's the next question. So if you're going to face it, you have to detect it early and treat it at the earliest. For that, PET is an important modality in detecting the cancer early and in treatment response evaluation. So this is one way we are helping the oncologists that, so that's a threat, but still we can face it. So cancer detection, the chronology is, first there will be at a microscopic level, there will be some anatomical abnormality happening. And second, there will be a functional change. And third, you can detect with a conventional imaging like CT or MR. So where we stand is in between the histopathology and the conventional imaging. So we are able to detect it early because functionally it shows some sign that we can capture with PET-CT. So early detection is the most important key which helps us in detecting cancer. As you see, the difference between radiology and nuclear medicine is radiology, the image is in black and white, and PET we can give color image. That's one simple explanation, but the color comes from the function. So as you see, there's a section of pelvis where you see a normal bone, but when you do PET-CT, you see that there is a lesion in the skeleton, which is not visible on conventional imaging, but because we are detecting it functionally, we are able to detect it early. So this is the basic difference how it is superior to conventional imaging. The most common PET what we use is FDG PET CT. That's the worldwide most common. If they say it's a PET scan, it's most commonly an FDG PET CT we use for most cancers. And second, we use for specific cancers like gallium DOTA PET, previously called as somatostatin receptor scintigraphy. Now it is DOTA PET that we use for neuroendocrine tumors. And third is the PSMA PET CT, which is exclusively used for gentlemen. And ladies are not allowed here because it's restricted only for prostate cancers. And for DOTA PET, endocrinology point of view, it's very important. There is a concern called tumor-induced osteomalacia. And this DOTA PET is the imaging modality of choice to detect the benign phosphaturic mesenchymal tumor that can change the patient management significantly. So a PET study has three components. One is the tracer we are going to inject. Next, we have to prepare the patient, and we need the mission. If all these three are available, only then we can do. If anything in this thing is not functioning properly, then PET scan cannot be done. So the FDG, it's commonly produced by cyclotron. Any radio tracer can be produced by three methods. One is cyclotron, one is a nuclear reactor, and third is the generator. So cyclotron in Kerala, we have only one cyclotron facility, that is in Cochin. So that is supplying this FDG all over Kerala. And the patient preparation, only one single request for the patient is to come at 4 hours fasting. And third, the PET CT machine, where the CT machine is combined with PET, and it is a state-of-art machine because it provides both functional and anatomical in a single shot. And DOTA and PSMA can be produced by an in-house generator that can be produced anytime, and we can do the scanning. And for DOTA PET and PSMA PET, there is no special preparation or contraindication. And PET CT, when compared to conventional CT scan, there is no contraindication for PET CT unless the patient is pregnant. So if there is a renal failure, or if there is a liver failure, or any other concern, bone marrow suppression, anything, the PET CT can be safely done. So there is no contraindication except pregnancy. And the advantages is a one-stop imaging, which can provide all functional and anatomical information in a single shot. And because it's a whole body imaging, we get to know all the details. And it's more or less similar to a virtual histopathology, where we can say this is malignant or benign, and if it's malignant, which is high grade or low grade. And it can help in planning the treatment and easier to manage the patient in current scenario, where the information they used to get it from internet, and they are so skeptical about how to proceed and everything. Patient itself know the management, so it's important to say and provide the proof that the diagnosis made, treatment is done, the patient is cured. So this is a rough estimate to show the importance how it can improve in diagnostics. So the conventional imaging and the PET, you can see the sensitivity is higher for in general or cancers. So how it is really helpful in diagnosing a few examples. The most important thing is the solitary pulmonary nodule, where you detect a solitary pulmonary nodule in a CT, and if you want to say it is benign or malignant, then you can do a PET CT where solitary pulmonary nodule showing an uptake has more chance of malignancy, and without uptake, you can say it is benign. And how to differentiate anatomical detected lesion, whether it is benign or malignant. As you see in this section of image, we see a mass in the lung with pleural effusion and associated findings. Now we have to define where is the mass and which is the benign consolidation part, and the pleural effusion what we see is metastasis or benign. So when we do PET CT, we can see that the image what we see is overestimated. Actual tumor is only restricted to the hilum, and whatever seen in the periphery or benign consolidation changes, and the pleural effusion is benign in this case. So this is the real difference where PET can really show how what is the tumor, whether it is benign or malignant, and how we can overcome it. And next, previously how important in diagnostic, and next how important in therapy. The patient with the radiotherapy, if you want to focus where is the tumor, exact tumor focus, then PET can detect the exact tumor focus so that they can concentrate the treatment part only restricted to that part. And another important topic in oncology is unknown primary, where the patient present in the retrograde manner, where they present with the metastasis, and now we have to identify the primary. That is one important concern. And PET can really helpful in these cases, where it can detect the primary and improve the detection rate in approximately 2/3 of the patients. And this is one classical example how PET can be actually important in clinical scenario, where the patient present with a brain SOL. Now the concern is to operate, to go for a big surgery to characterize the lesion. So when we did PET, we found there is a single focus which is sub-centimetry. Even a conventional CT scan, we might do overlook it and we might miss it, but in PET we found that lesion. And now the patient management differs. Instead of going for an invasive brain surgery, the patient underwent a bronchoscopy biopsy of that lesion, and that was found to be an occult CL lung. So this is how it really helps in management in real life scenario. And most important indication for PET-CT is lymphoma, where it can actually stage and helpful in diagnosis and a treatment response. This is a whole body image where you can see the lymphoma spread above and below diaphragm lymph nodes with splenic involvement. And after completion of treatment, it shows complete remission. And the patient is confident, the treating oncologist is confident that the patient is treated and the patient is in remission. So why PET-CT is important in oncology? Because it changes the management in approximately 50% of all cancer treatment after a PET is done. And coming to the next few important PET-CTs, the second is a DOTA PET. Previously, whatever discussed is the commonest PET like FDG PET-CT. Now, specific PET-CT traces. One is DOTA PET. It is the advanced somatostatin receptor scintigraphy. Previously, older days they say somatostatin receptor scintigraphy is the imaging choice for neuroendocrine tumors. Now, DOTA TOC is an advanced somatostatin receptor scintigraphy. And what is the indication? If it is a well-differentiated NET, you go for a DOTA PET first choice. And if it is a neuroendocrine carcinoma, a higher grade of neuroendocrine lesion, you go for PET-CT. So this is a slide to show how a well-differentiated NET in the pancreas can be detected by DOTA PET, and the same lesion, if you do a PET, it is not showing uptake because these are well-differentiated tumors, and neuroendocrine tumors express the somatostatin receptor, and we are exploiting that property functionally, and we are able to detect that lesion. And previous when Dr. Abdul Malik was speaking, there was a question whether there is any targeted therapies. So this is one example where we can exploit nuclear medicine into theranostics. So we can see this case of a large carotid body tumor with metastasis, and that was detected with a DOTA PET because they express somatostatin receptors. Now, because it is metastatic and widespread, there is an option called a peptide receptor radionuclide therapy, where the organs which express somatostatin receptors can be targeted with lutetium-177. That is a tracer that can target this pheochromocytomas or carotid body tumors. So you can see after the treatment, there is significant decrease in the primary and the metastatic lesions. So a targeted therapy is available in nuclear medicine, especially for neuroendocrine tumors, metastatic pheochromocytomas, paragangliomas, and CA prostate also we use a tracer called lutetium PSMA therapy. So this is coming in a big way, and it is now in common practice where we use it for advanced metastatic neuroendocrine tumors. And coming to the next tracer is PSMA PET-CT. This is coming more common because of this, I am getting more friends in Calicut, especially the senior citizens, they're all friends to me because after 60 they used to come for this PSMA PET CT. Even without consulting a doctor, they come in private to check whether they have a prostate cancer. So the major indication is for lesion characterization, initial staging, recurrence evaluation and restaging. And when it is metastatic, not controllable with usual modality treatment, then there's an option called PSMA lutetium therapy, targeted therapy again, where we can actually have a significant difference in overall survival and progression-free survival. So this is just an example to show the importance of PSMA PET CT scan, where you can actually detect a recurrence after surgery. And second, whether the metastasis is active or a healed one, where in this case you can see an active bone metastasis, but conventional imaging will show a sclerotic lesion. You cannot say whether it is a healed lesion or an active lesion. But PET can differentiate between an active lesion and a healed bone lesion. So that's how PSMA PET CT is more helpful in prostate cancer management. And this is a slide to explain the diagnostic part of lutetium PSMA therapy, where initial scan you see there is a disseminated bone metastasis, and after sequential lutetium therapy, the patient is almost in near total resolution. The PSA was initially 387 as reduced to 1.08. So this is how you can actually change, make a difference in CA prostate management. So before concluding, I would say that nuclear medicine is very simple. The spectrum is wide. Whatever I shown is a representative image, and when you sit for reporting, there is always surprise. And if you love surprise, it will be challenging. And that challenge is the one which makes us interesting and passionate about this imaging modality. Before reporting PET CT, anybody in general in imaging, the mind should be open. Because if you're not able to, the same image can be seen by each and every doctor. But how you're going to see the image is different. You can find more information if your mind is open and if you're ready to unlearn and relearn. Thank you.
Thank you, sir, for that detailed talk on how PET CT ranges from just being, from not just being a diagnostic modality, but also being a therapeutic modality. Any questions?
Is there like any contraindication, like for example, somebody who cannot receive radiation, like you have P53 leaf harmony where we say we try to avoid radiation, do MRIs. Would it be safe to do a PET in that patient? And second question is what patients always ask us: how many PETs are safe? What is the upper limit? You doctors keep asking me to do a PET. Is it safe? What's my increased risk of cancer? So recently that's a question asked.
PET CT is not without radiation. It has the CT component, so the radiation is definitely there. But what we use in PET CT is a low dose CT, and the tracer what we give is very minimal. We are following the principle called ALARA, as low as reasonably achievable radiation. That is the main principle to be followed in any radiation modality. And when we compare a PET CT with a triple phase CT, the radiation dose is very less. We are doing a whole body CT, but not in sequence, just a whole body low dose CT. But what you do in a triple phase CT is like you do a plane, you do an arterial phase, you do a portal phase. So we are trying to maximum reduce the radiation, give the maximum information. If the the first question is P53 mutation, if the counts are very less or there's a significant difference if there's going to be radiation, then it's better not to do. Only you have to weigh the balance between the benefit and the risk factor. If this won't be really useful, if you think that clinically it makes a significant change in the management, then go for PET, no issue. Because we will do a low dose CT in that case. And minimal radiotracer will be injected for that patient.
Another doubt we have is when patients come for screening, mostly bystanders. So can we also do a PET? An asymptomatic patient. That's a very common question.
No, I used to get patients when they come straight away from Arabic countries and they say, I need to check because I'm going there for 2 years to screen cancer. I said, no. You go visit a family doctor. If the family doctor is saying something suspicious, you visit an oncologist. The oncologist says yes, I can do it. I can't straight away take the patient, and screening is not indicated because it involves radiation. Even though if it's less radiation, it's not indicated in this case.
For patients who have P53 BRCA, those patients where we tell not to have X-rays done, even diagnostic X-rays or CTs or MRIs, the general population, like we all have a certain limit. So basically it's a bureaucratic decision that they make. Radiation workers have a limit, the doctors have a limit, and the general public has a limit, 20 millisieverts, 100 millisieverts. So these are just bureaucratic decisions, basically for radiation safety and all this. But I would say for a patient who is at inherent risk of cancers, who are supposed to be hypersensitive to radiation, like P53 and all those patients, I think it's better to adopt some other modality, MRI, mammo, some other thing, like ultrasound for screening, not to expose them to radiation firsthand. Or do it only like if you have very clinical indication. We are giving radiation for those patients.
We are not usually using the PET or CT for screening. Only mammography is kind of MRI.
But that is again X-rays. Mammography.
Ultrasound is
Ultrasound.
Mammography is
X-rays.
Whole body MRI.
Unless there is a strong clinical suspicion, you don't involve radiation.
So the digital mammogram has less X-rays, but if you have young patient who has a family history and you are suspecting that a patient would be having a familial syndrome, don't ask them for X-rays or mammogram also. You get ultrasound mammogram or MR mammogram. Young patients especially.
That's done for the UTMR. Is there
MR mammogram.
But it is very, very rarely, very, very rare.
But now we have detected few patients who are these P53 related.
What is very false positivity in practice? Because many times false positive.
PET CT cannot detect cancer. It can detect a cell tissue with as an aggressive glucose intake. That is the concept. So false positivity will be there in inflammation and active inflammation. But it is the reporting person, if he is well versed with the pattern, then he can able to differentiate. But false positive in general, if anybody can report, they can say that is false positive. But the pattern, the clinical history, everything should be taken into concern. Then we can actually differentiate because we can quantify the amount of uptake in PET scan if that is correctly done. And that is one important factor. Second, clinical history and the pattern of uptake, that is more important. SCV in general, you say it's more than 5, it's more towards the malignant component, but not always.
Thank you, sir. We'll go on to our next talk.
Thank you.
Thank you, sir. For our final session, let me welcome Dr. Lily M., Senior Consultant and HOD Pathology Astronoms, who has graduated from Government Medical College, Toronto. Welcoming you, ma'am.
I welcome Lily ma'am. We are very fortunate to have Lily ma'am here today, and we are very fortunate to have been associated with ma'am from beginning of the institution. Lily ma'am has the largest experience among pathologists. She has more than 4.5 decades of experience. And with this vast experience, I am sure she will enlighten us on importance of pathology in oncology. Welcome, madam.
Thank you, doctor, for the nice words. Very good afternoon to all of you. I assure you I will not take much time. Dr. Arun, I will not do any harm to the patient. I will only deal with a very little bit of tissue is submitted to me. Okay. Oncopathology, as you know, is a branch of medicine that deals with diagnosing cancer through an array of tests See, in olden days there were only very few tests, but now we have an array of tests ranging from we can test body fluids and tissues, and the tests are very a large list of tests. I will come to that later. The diagnostic accuracy has also improved with new technologies. We can that further classify cancer, identify specific genes, specific proteins, and specific mutations. And communication between the oncology team and the treatment team is very crucial for us. As Dr. Sellam was saying, inflammations in the body can produce reactive changes in the tissues. So unless we get the clinical scenario, there is a high chance that we might go wrong. So that is very important. Now, coming to the steps in diagnosis, all of you are familiar with the FNAC, fine needle aspiration cytology, that we do to any visible swelling. I will not go into the details. But there can be failures when we do an FNAC, because sometimes the aspirate may be very minimal. Whenever you aspirate, you have to be careful. It should be fixed immediately, and it should be fixed in isopropyl alcohol. The slide should be completely immersed in the fluid, and it should be fixed for a minimum of 1 hour. See, sometimes I'm seeing the clinician, especially the junior ones, waiting for the sphere to get dry. That is very wrong. You have to put it when it is wet. Then only the fixation will be optimum. Then another method is in cytology, we look at the cells only. We see the scattered cells. Whereas in histology, we get tissues, piece of tissue, maybe different types of biopsies. And these are the different patterns we see. Very colorful, no? The others were all saying black and white. Sellam only showed some color. But we have a range of colors. And it will be very interesting to look at the patterns and make a diagnosis, provided you give us the relevant clinical details. The pre-analytical phase is also very important. The fixation is very important. The correct patient identification using barcode is important, because a small error in these areas can bring about a very serious mistakes. Labs should have their own referral form. The clinician should give the age, his clinical diagnosis, and preferably the radiologist diagnosis. That will help us a long way for us to evaluate the tissue. The tissue should be fixed in 10% neutral buffered formalin. And see the first picture, a large specimen should not be squeezed into a small container, because as it gets fixed, it will become hard. So it will be very difficult to take out the tissue, take out the specimen, and it will distort and it will interfere with the organization of the tissues. Second one, you can see the bottle, it is not closed properly. So the contents have spilled, the fixative has already spilled, and the tissue has come without any fixative. The next procedure we do is the very important procedure, that is frozen section. As you all know, while the patient is on the operating table, a small piece of tissue is sent to the lab, and we can make a diagnosis within 30 minutes. And this can modify the type of surgery, whether it is going to be a radical surgery or a simple excision. That's the importance of frozen section. Now we have immunohistochemistry. By this process, we can selectively identify antigens or proteins in the tissues by exploring the principle of antibody binding to specific antigens. See, it is a very simple and very powerful tool. It can be performed in the formalin fixed tissue. You have already said to us the same tissue can be used for immunohistochemistry. We have commercially available specific antibodies. We can add this to the tissues, and if the corresponding antigen is there in the tissue, it will give a brown staining. Hereby, we can classify the neoplasms, determine the site of origin of a metastatic tumor, and therapy-related like HER2 breast cancer, IDH mutation in brain tumors, etc. can be detected. See here, Dr. Sellam was saying he can identify an occult carcinoma in the brain, occult lung carcinoma in the brain. So if he suspects lung carcinoma, we can take the tissue and do TTF or a napsin A to pinpoint that it is a lung cancer. Then we follow the CAP protocols proposed by the College of American Pathologists. It is structured synoptic reporting using tools like CAP cancer protocols. It can improve patient outcome. Dr. Rakesh was telling you about the TNM staging. This is an extended version of the TNM staging. Here we also look at the margins, if the margins are involved, if the margins are free, what is the clearance of the margin from the tumor, how many millimeters, it can be measured. Then we can look for perineal invasion, vascular invasion, and so on. So the CAP protocol is a must for reporting, so that the reports will be uniform and accurate and will standardize the treatment protocols. Then another method is molecular pathology. It's an emerging discipline within pathology which focuses in the study and diagnosis of diseases through examination of molecules within the tissues and body fluids. This led to the use of targeted molecular therapy in tumors. We have been telling about the targeted therapy. We can identify specific mutations by immunohistochemistry, and there are drugs which specifically act against these mutated cells. So the treatment can be more individualized and it can improve the patient outcomes. Then another technique is FISH. It consists of hybridizing DNA probes which are labeled with fluorescent nucleotides. It can detect gene fusions, presence of abnormal chromosomes or loss of chromosomes, etc. Example, BCR-ABL translocation in chronic myeloid leukemia, ALK rearrangements in pulmonary adenocarcinoma, HER2 amplification in breast cancer. The next generation sequencing, these are all highly sophisticated tests which can be coming under molecular pathology. It detects a broad spectrum of genetic variations. It can investigate specific set of genes, whole exome sequences, whole genome sequences, etc. For example, RT-PTC fusion in a papillary thyroid cancer, EGFR, ALK mutation ROS1 in lung adenocarcinoma, KRAS mutation in colon cancer, etc. So the molecular alterations have also become an integral part of the histopathology report. Now, pre-analytical and analytical challenges, we have to be very careful. The fixation should be optimum in order to detect all these mutations. The tissue has to be preferably fixed in 12 to 24 hours in neutral buffered formalin. Short fixation can cause enzyme degradation, and longer fixation may lead to DNA and RNA degradation. While section cutting, we can also be careful to minimize cross-contamination. Then bony samples have to undergo acid fixation for PCR-based sequencing techniques. EDTA or formic acid-based recalcification is suitable for PCR-based sequencing. For tumor lacking adequate cells, marking the area of viable tumor cells can also be useful to do molecular markers. So there are a lot of precautions to be taken if you are going for molecular pathology. You should be aware of all these, and I am sure today's session has kindled an interest in oncology, and you'll be eager to learn more about oncology. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. It was an excellent talk. Madam also told common pitfalls in preparing a specimen and sending it, and also she told stepwise how we can process a specimen and finally arrive at a diagnosis. Now the topic is open for discussion. Any queries if you have, you may ask.
Is there two things? Is there any scenario where the IHC can be false positive, like not negative but positive falsely? And second, is there a role of artificial intelligence in pathology coming up? In medical oncology, they have the IBM Watson, which could predict, the treatment protocols and everything. In pathology, is it coming out there? Would it make our, jobs a little more dangerous? That's the second part of the question.
Okay. About the first thing, can we have false positive in immunohistochemistry? The thing is, the same marker can be positive in different tumors. So we have to do both positive markers and negative markers to arrive at a diagnosis. The staining is also specific. It should be either nuclear or it should be cytoplasmic or cell borders. We have to look for the specific staining. In that case, the false positivity will be minimum. If an inexperienced person, if ideally it should be cytoplasmic staining, but if he takes the nuclear staining as positive, then he can go wrong. So it's very important that we should do positive markers and negative markers in order to arrive at a very specific diagnosis. Now about artificial intelligence. Yes, artificial intelligence is coming up in a big way in pathology also. Now we have digital pathology where it allows us to look at the screens and do the reporting. We are also familiar with that because nowadays we don't send glass slides. All the slides coming to us are through images. So we are familiar with that. And a software is being developed where the computer can detect if there is necrosis, then that will say necrosis, then mitosis, everything will be counted. Finally, the software will tell you whether it's a malignant tumor or a benign tumor. That is coming up in a long way. We can expect it soon. But I think, as in any machine, it can go wrong. So the pathologist will always should be around to manage this. That's what I feel. Thank you. Any other questions? Yes, yes. Fixation can affect all further tests can be. Optimum fixation is the key to a good test. That's very important.
Why I asked was, my wife had breast cancer and ISC was positive for herpes. And within fission it is different, they could not give it. That's why I just asked why it was very clear in ISC.
Yes.
And fish has not shown.
Yes. Inconclusive can occur.
I have a small doubt. Between benign nevus cells and malignant melanoma, when we fail to differentiate morphologically and HND, are there any other way of diagnosing? I heard immunohistochemistry cannot distinguish benign melanocytes and malignant melanocytes.
But morphologically we can the nevus. You said nevus and malignant melanoma.
Yes, ma'am.
See, nevus, we have to, very often it is intradermal, the epidermis will be free. In a junctional nevus, there will be junctional activity. But in a melanoma, the morphology will be different. Nevus cells are almost uniform in size, whereas the melanoma cells, they are very large with it. Of course, the melanin pigment is the key to identify, the marker will identify the melanin pigment. So both will be positive. We have to depend on the morphology and the clinical and the clinical details. The clinical appearance. A melanoma, it has very specific clinical features like ulceration, rapid growth, infiltration, etc. So the clinical details are important. The Ki-67 proliferation index can help us. It will be low in a nevus, it will be high in melanoma. I think melanoma should not be a problem to differentiate it between any nevus.
My question was, like sometimes surgically a pigmented lesion is excised.
Yes.
And the patient comes back again with some lesion, and when he has lost all the previous records. And in this one, we find difficult to differentiate morphologically whether it is nevus or malignant melanoma. So, is there any molecular studies by which we can confirm it?
To my knowledge, there is no molecular study for that.
Okay.
We go by the morphology.
Okay.
Recurrence can occur in a nevus if it is incompletely removed. But there should not be a problem if there is melanoma.
Thank you.
In oncology, one of the markers we check for therapy purposes is BRAF mutation. But again, that's not normally used to differentiate between benign and malignant. But 50% of malignant melanomas which are cutaneous will have this BRAF mutation. 10% of cutaneous melanomas will have also this BRAF. So if you find a BRAF positivity in a thing, then I would more maybe think of malignant melanoma.
Thanks.
Thank you, ma'am. Thank you, sir. We have completed the sessions. To hand over the memento to Lily, ma'am, may I request Dr. Konapur, sir, HOD Pathology, to kindly come forward. May I request Dr. Sarah Chandi, ma'am, to hand over the memento to Dr. Keshavan. May I request Dr. Wasif, sir, to hand over the memento to Dr. Abdul Malik. Requesting Dr. Yashwini, ma'am, to hand over the memento to Dr. Salim Karnataka, sir. Requesting Anish Bajaj, sir, to hand over the mementos to our chairpersons. Dr. Sarah Chandi, ma'am. Dr. Wasif Mayank. Dr. Yashaswini. Dr. Kanapur.
lunch.
Quiz session will be followed by after lunch. Will be continued after lunch. Thank you.
They omitted the panel discussion because